Again, first of all, I'd like to thank, STRYKER for putting on this incredible course. Obviously, it's very rare that you can get to see 2 live cases or 3. We have 3 prepared, so that we can show different techniques and stuff. Again, we're all learning together. Ajit and I have done a few, and we've done enough. I think we've done a couple live now. But I can tell you that, every case we continue to learn, and we really look for all your advice and your suggestions as we go forward. Again, I'm just going to introduce the team. Of course, right next to me is my partner, Dr. Ajit Rao. He's the director of vascular surgery research here, and he works very closely with us here in the cardiac cath lab. We do a lot of cases together, live cases, and so on and so forth. To his right is Dr. David Song. Dr. David Song is our junior attending here. He has been integral part of developing both the PTAP program as well as the PDAP program, and also really doing incredible work with critical limb ischemia and taking care of all of our patients. Behind is Dr. Michael Sola. Michael Sola comes to us from North Carolina, University of North Carolina and Rex, and he's an interventional cardiologist, trained and board certified, also obviously a general cardiologist, and he's spending a year with us. He's one of our 3 endovascular fellows that we train every single year to obviously go out and treat the disease. Our nursing team is Elizabeth Holton. She's been with us for over 20 years, and then Reka is here as well, and Reka's been great in helping us set the patient up. Outside, we have Damien and Ramon, who have been incredible in getting this patient together. So again, thanks again for your patience, and we're ready to start. Mike, you want to present the case?
Absolutely. So this is deep venous arterialization of the right lower extremity. So history of present illness, we have a 60-year-old gentleman with a past medical history of hypertension, hyperlipidemia, poorly controlled type 2 diabetes, coronary disease, heart failure with reduced ejection fraction of 35%, with PAD with multiple prior interventions, with ongoing poor wound healing of his right foot. The patient required deep venous arterialization of his left lower extremity due to prior non-healing wounds with successful healing after a toe amputation on the left side. Now, he has poor wound healing of his right toe, has undergone prior intervention of his right PT without improvement, and he has severe pain ongoing. Venous mapping was performed, which did not show adequate size veins for bypass. He presents today for deep venous arterialization of the right lower extremity due to non-healing progressive right foot wound. Bypass was believed not appropriate due to his medical comorbidities, no adequate vein for bypass.
So then, I mean, as you can see, Ajit, you want to comment? I know, so Ajit and I did a couple of interventions. The last one was done by Ajit, and we can show the films, but Ajit, what did you find?
Yeah, so, everything looks good up until the tibials, pretty healthy, as expected, diabetic and everything. But then once you go below the ankle, kind of, the PT, which was the primary runoff, tapers off. The perineal doesn't do much. The AT doesn't do much. So just kind of a desert foot, nothing below the ankle. I did try the PT had some disease, so I actually did angioplasty. It was pretty challenging. It's very calcified, nothing would track. But I did get a decent result. Despite that, the wound still didn't heal. We debrided it, and it kind of just got worse.
So, so you can see here, so just because it's a live case, normally we go antegrade direct. With the live case, we always get contralateral access just for safety. God forbid we need to tamp it out of the common femoral or what it is. So we just took a shot of the iliacs. You can see the iliacs are clean. Then we went ahead and got obviously antegrade access. You can see the prior antegrade access with the KELT device giving us a nice target. And then so we went ahead and then we put a 7 French 55 centimeter sheath through this all the way down into the popliteal artery. You can see here we're tracking the supercore into the AT, and we'll show you the angiograms slightly, and I'm going to have Ajit just read the angiograms here. There we go. This is the selective.
So yeah, our sheet's already in the popliteal here. And you can see proximally looks pretty good.
Sorry.
You're good. I think one back, maybe?
There you go. Oh, yeah.
One back. We'll just show the pop.
There you go.
So yeah, distal pop's fine. Tibials, you can see some disease, but nothing horrible proximally. But then as you kind of march down, it gets progressively worse. And the perineal AT start tapering off, very slow flow. And you can see that, so this is the angiogram from today. I did actually angioplasty the PT before and got a better result than what it looks like here, but it still didn't heal despite that. And then once you go below the ankle, the PT kind of tapers out, and his wound is on his toe, and you can see there's really not much getting there. No pedal arch, no pedal loop. You know, I tried good wound care. We even tried home oxygen. We obviously treated the PT, but it still didn't heal.
And so, so you can see that the forefoot, which is what needs to be perfused in this guy, really is not getting much perfusion from either the PT or the perineal. And this is the kind of guy that, in the left foot, when we did the DVA, he had a similar picture, and he healed up very, very well, and the left foot is still intact. So he did well. So this is kind of where we are. So I'll just go through some of the steps. So Ajit and I, what we did was we have actually cannulated. I'm going to go live now. We've actually cannulated our 7 French sheath into the proximal AT because of the bend. And obviously, the plan here is to do a DVA of the anterior tibial. And maybe you want to comment on that, and maybe Stephen, you as well?
Yeah. Oh, yeah, go ahead, Stephen.
I haven't had a whole lot of experience of AT because the AT system, as you know, as we spoke before, the AT and the DP vein are really very small. And once you go past the DP, once you go past the ankle, you probably have to stent your way down to prevent the veins from the anterior part of the leg from crushing. But as I mentioned, if you can get blood into the deep plantar arch, you've got to win. So the real question is, where is your donor artery? Is the AT a good donor artery? Is the perineal a good donor artery? Certainly, doing it off the posterior circulation will be a little bit of disaster because you're taking off all the native circulation. So I think the baseline is you got to be adding blood flow to the leg. So I think you could consider the perineal, you could consider the AT as well. But I'm interested to see you do the AT. If that doesn't work, then do the perineal.
In our series, Ajit and I also don't have a high experience with AT. We've done, I think, 1 AT and 1 perineal so far. Most of them have been obviously lateral plantar and the PT. So like the next case is going to be. But this case, as you said, Ajit and I spoke, and we spoke with you last night. The heel will become ischemic if we go off the posterior tibial. And I can do a lateral picture, which will clearly show that the heel perfuses from that posterior tibial artery, and it seems to be the major artery into the foot and the donor artery. We could balloon tamponade the posterior tibial and inject into the perineal, and then see if the perineal fills the foot. But looking at this angiogram, it doesn't look like it will. But we could do that if that's what you want us to do to see the viability of the PT.
I think give it a go. Try the AT and see if we can get the AT going. If you can hook up the AT, then drinks at the house.
Any thoughts from our any thoughts from our audience? Any thoughts from our? I mean, we have such esteemed vascular surgeons and cardiologists. Anybody there? I mean, any thoughts on these kind of wounds? I mean, it's not a large wound, but it's a very painful, and it's not been healing in over 7 months. Mm-hmm. We've been dealing with this guy, and it's extremely painful for him. And obviously, since the opposite wound healed, he wants something done.
Yeah. Can I ask a question, PK? Can you hear me?
Yes. Yep.
So I understand. Ajit mentioned that he did the PT already, but the truth is, you look at that angio, there is a vessel going out to the toe. You have an occlusion at the PT at the ankle. You have other stenosis and all that. I'm a believer of the coronary stents or whatever, absorbable scaffolding. I personally, I wouldn't consider this maximized in terms of arterial healing before doing something. Was that achieved previously and it closed in the short term? Because otherwise, why not open that PT all the way to the foot?
Yeah.
Go ahead, Ajit.
Yeah, that's a good point. So, we did angioplasty. This is the angio from today, so everything recoiled. And I'd be hesitant. I mean, I definitely, believe in the bioabsorbable stents, and I think I have had better outcomes with them so far. But I'd be afraid to treat that distal lesion there with a bioabsorbable stent because it's pretty close to the ankle and the flexion point. So, I wouldn't feel comfortable. And the other thing was, when I tried to treat this, it was very difficult to even track like a coronary balloon down. So I don't know if I can even get an SPRE down there. But those were the caveats.
And also, Al, I think at the level of the ankle is where, the problem is. It keeps recoiling also proximally. We could put proximal stents, but if you look at the perfusion of the foot, it's not, the wound, again, you saw the picture of the wound. It's actually around all the toes. The entire toes are covered. And I think that this guy is probably going to need a major debridement of the foot. I'm not doing it, but Ajit can talk about that. And I think, with this kind of flow, I just worry that if with that PT alone, known, is it going to be enough or not? Now, we did try the anterior tibial, the native. There's nothing in the foot. The wire went. You can see the wire pretends to go all the way down into the ankle, but there's really nothing there. And the perineal has nothing. So the idea here is it's a lot of twigs. I think it's an orphan forefoot without much perfusion, and that's where obviously you have the heel, or I should say the orphan dorsal aspect of the foot is what I'm thinking.
PK, could you give us an AP shot of the foot?
Absolutely.
Yeah, just like.
Oh, well, actually, shit. You know what? If I do, I'm gonna have to lose my. So what we did here is we tracked the device into our sheath into the AT, because in order to track the lymph flow device down, that's a right angle bend, and that right angle bend is going to be a problem. Now I can inject through the AT, but you're not going to see much. So the idea here is, I'll give you a better injection, but we'll have to pull back and then redo it. So let me do that for you guys.
Okay, don't do that, PK. We might not be able to get the sheath in again, so just leave it.
Yep. Yeah. So you can see our pressure. Our pressure is damped completely in the AT. We're actually tubed into the AT because we're worried about tracking the device, even though we're antigrade. There is quite a bit of calcium. As you can see by the fluoroscopy on the PT section, you can see the calcium running there. So this is a very calcified, stiff vessels, and so I kind of want to leave my sheet there. So with that, Stephen, I've just got a grand slam in the AT, and I'm just going to show you guys the venous anatomy. We have our wonderful technician here who's here to help us if we're not able to see much. But you want to just go over the anatomy with the ultrasound? Can you go live on the ultrasound, guys?
Yeah, let's pull up the ultrasound here.
There you go.
Okay. So here, so you guys can see this?
Yep.
Okay, so you can see pretty diseased. I'm in the foot right now, so that's the DP. You can see super calcified. So I think when we do the DVA, we're not really going to miss that vessel at all. And then can we go up with a tourniquet too? So in my opinion, I think this is one of the most challenging parts of the DVAs, getting access. You may be fooled because if you do a lot of RFAs, you get access all the time, but these things spasm a lot. They're angulated. It's not a straight shot. So I always put a tourniquet up. We always do that. We're heparinized already. And then here you can see kind of the DP diving down there, the DP vein. So just even if we're doing the PT, DP, you always want to go as distal as you can, so that way you're not dealing with as many valves. So I'm going to try to access it basically kind of as it dives down right there.
And in contrast, why don't you show them the posterior tibial, the size of the posterior tibial, because it's incredible the contrast. Stephen, you have a theory on how it's like look at the size of that thing. Yeah, how it's like a sump of the leg, right?
Yeah, it's the swamp.
Swamp. Yeah, exactly.
Swamp. Swamp is the Donald Trump thing, right? Swamp.
Yeah.
Swamp.
Some bumps on the swamp.
Swamp. Drain the swamp. That's right.
Yeah.
So it's a lot bigger, obviously a much more juicy target, but unfortunately in this case, with the heel being perfused by the posterior tibial, we'll probably steal from the heel. So we're going to go with the DP here. So we're going to get access again under the tourniquet. I'm sorry?
Oh, I just told him to decrease the depth.
Oh, okay. All right.
Okay.
So we're going to get some lighter. You need lighter?
Yep, I'll take some Lido.
Here.
So PK, this is Bhaskar. I had a question. Do you recommend getting a prior vein mapping done to see if this procedure is technically feasible?
Oh, I think Bhaskar, the company is phenomenal with providing, support. I think STRYKER is very serious about this product and about promoting this therapy, and they're always available. As you know, you trained here with me, and in New York, getting the patients in 2 or 3 times is very, very difficult to get this vein mapping. So what we do generally is admit the patient, and we do vein mapping on the day. We have had patients where we have not had adequate vein and had to not do the procedure, but that's the issue. So yeah, I would recommend you doing vein mapping it out, and we're lucky enough to have the patient in. We actually draw the vein on the foot to actually show where we're going to get access prior to obviously making the foot sterile.
So I'm trying not to manipulate it too much.
Perfect.
I'll be completely honest, I was dreading this a little bit because sometimes we can struggle with this access, and there's a whole group of vascular surgeons that are judging me in another room, but we'll see if we can get it.
And
one of the things that we have it in the next tips and tricks. But one of the things I do is sometimes I put a vannula into the medial
Can you
marginal vein
tell
or the great saphenous
Damien,
vein
we need
and
2
fill
more
all of that
Australian
with
wires?
warm saline. that is below the tourniquet.
Yep,
And the
you're in.
superficial venous system will help to fill all the deep veins and make it a little bit easier to stick the vein.
So,
But it
so,
can be very tricky.
and also notice, Ajit and I flipped on who's going to do the posterior tibial vein, and I won. So, you know, hopefully I'll look really slick later on. No, I'm joking. We do everything together here, so it's a lot of fun. You know, it's so wonderful to work as a team. Mag up, guys, for him. Can you bring the angio up and get rid of the
Yeah, let's put
ultrasound
the-
for us, so Dr. Rao can see.
So I was getting blood back, but
AV team, thank you.
wire's not tracking so far.
So again, the idea here is to try to get as distal as you possibly can. And again, as you can see, these are very small veins, and we may do what Stephen said. In the next step, we may just inject.
So, can I ask you a question, PK?
Yes, sir.
You made a comment about worrying that if you use the PT's vein or tarsal vein, that it may steal from the heel. Will it, or is you're going to perfuse that deperforated to the PT anyway? So why not access below and try and make the turn, or is the turn too challenging to make from the bottom around again?
I mean, oh, you mean into the DP vein? I personally think it's very challenging. I mean, you can try and definitely try to do that. But Stephen, have you done that? We've never done that. We've always gone this way.
The DP vein can be really, really small if you cut on a cadaver. So I think it's worth giving it a bit of a shot and see what happens. The things that we do to dilate it, you can put fluid in and so on and so forth, but anatomically these veins are very small. And when you do a distal DP bypass, you always clip these veins off and you forget about it.
Yeah, the reason I ask is I'm seeing the needle and the trajectory.
Yeah, so that's my needle tip there. I don't know if you guys can see it, and I'm getting blood back, so I think I'm in the vein. It's just trying to get that angle to
I'm
go
just
up.
looking at the way it is. I mean, if you hit the, again, I'm just suggestion, if you hit the PT vein from the bottom, making that loop through the perforator back up to the DP vein, may be more of a soft curve, you know?
Absolutely. No. I think we will definitely try that. I mean, like I said, we've had an N of 2 on the DP, and we've been able to get through. It's a bit of a struggle. You'll see. Hopefully, if not, obviously that'll be the alternative.
That's a DP vein you're doing right now, right?
Yeah.
Yeah.
Just looking at the trajectory, it's going that way rather than.
Normal alternative is to hit the AT higher up and then
Yeah.
connect it up and then come down again.
Yeah. That's
once you've,
That's exactly the backup, Stephen. We're going to try here. If we're not able to get through here, we're going to stick higher, and then we're going to connect, and then we're going to come from above down. But as you know, it's a lot easier when you have through and through access lower. So that's why we're giving it a struggle here to see whether we can get through.
And then you lice the
I can't
valve.
see this wire at all.
Okay.
Can we get a different? Can I get the other one?
Yeah. Yeah.
cross.
Let's just flush it and start again.
You have to cross those valves on the way down.
On the way down.
So yeah, I think we try to start as distal as possible, but if it's not working, then we'll go a little more proximal. Can we go live on the ultrasound again?
So go back to the ultrasound, guys.
And the other thing I don't want to do is I don't want to spasm this. So rather than struggling, I'm just going to go higher.
We're just going to go higher, and then we'll make the loop the other way.
I try to go where it kind of dives down. I'm just going to go right above it. So we'll go there.
Well,
Stephen, you were saying something?
yeah, what about just above the ankle or, a little higher, straight part of the vein, and you can stick it? That might work as well. If you're having difficulty doing the image, because this is just around the bend of the ankle. So a straight portion, as long as you're able to connect up and down, and you can cross the valves a little bit later on.
Yep, yeah, we're in the vein again. This looks like a little better flow. Let's see. Again, it looks, obviously, I really believe the PT is a lot easier. Obviously, we've all talked about it. Hopefully this one seems to be moving a little better. Let's see. Let's see.
Can we put the X-ray back up?
Put the X-ray back up, guys. Okay, yep.
See that?
It gotta be off,
I
Laura.
don't know.
Gotta be off.
No.
I don't know. It looks good, but it doesn't really look good.
No.
Oh, yeah.
Yeah, but I'm not up there yet. That looks better.
There you go.
Good. Yeah.
Okay, good.
Yeah, there we go. All right, nice. All right.
Thank God.
All right. Now the problem is, Al, I got to buy him a beer now.
Can we deflate the tourniquet? Or actually,
Let's
should we
do a
keep the
picture.
tourniquet
Let's
up?
do a
Yeah.
picture first. So one of the things we do is once we're in, we're going to insert a micropuncture needle. We'll take a shot of the foot. This is, again, something we learned from Steven, to be able to do it. We did a live case where Steven moderated, and he actually walks through all the steps. And this is a great trick because with the tourniquet up, injecting, you can actually see the venous arch of the foot and really understand what you're going after. And obviously having Steven here is wonderful, so we can at least have a discussion as to what he sees and what it is.
Okay.
So now we got the tourniquet up, and we're just going to give Ajit a little dye. You got a little dye from him, bro?
Yep.
Thank you.
Thank you.
All right. So Steven, what views do you like
I
here?
might need more contrast in this. Can I get 10 cc's?
Yeah, I think probably a lateral foot if you can.
Yep, I'm going to do that right now. Watch out, brother.
Yep.
Oh, let me move this over. Careful. Sorry.
No, you're good.
Again, I know everybody here, radiation safety, unfortunately, this is a difficult procedure, and as vascular interventions, we're always hanging over the II. So is that lateral enough, Steven, or you want me to radiate more?
I think.
Yeah, just give it a go.
All right, we'll go a little lateral here, a little more there. Oh, too much. Right there. Let's try this.
Yep.
Ready? DSA, brother?
You're on DSA?
We're in DSA.
Okay. All right, so a little injection.
I think you're above the tourniquet.
Yeah.
Yep, we're going to come down now. I'm going to pull it down.
Okay. All right.
Above the angle, but
Let's try
you know
that.
what, PK?
Yep.
Don't lose the access. Make sure the wire goes back up again. I'm always.
Yeah, I pulled it back a little bit. Let's try.
Let's see. Let's try one more.
Yep.
Yeah, still might be above it.
It still might be above it.
With the tourniquet on, so you can fill
Right.
the whole thing.
Can I get more contrast?
Yes.
You don't want to lose the access, though.
10
Yeah, I'm not
cc.
going to pull it
Yeah,
back
we're not
anymore.
going to. Yeah, well, let's put a
You're
sheet.
gonna see much because if you pull back, you'll end up just below the tourniquet. So maybe just.
Do you want another contrast?
No, it's all right. I'll
Yeah,
take the
we're
wire
just going to go ahead and put the
for
wire
this.
up.
Oh, look at that.
for the slender.
We're going to put
That's a
the.
great saphenous vein.
Do you want a
Is that-
supercore or what?
Is that the
The wire for the slender sheet.
I think that's the AT vein, bro.
That's AT.
Supercore, right? Let's get a supercore.
Well, the slender sheet, I need the 014.
Oh, yeah.
Unless we
Actually, give
switch
us an
that way.
018 V18. So we're going to use a V18 to track the slender sheath up. So we put a 4.5, is it now this time? Right, we're doing a 4.5 slender into the DP vein.
Uh-huh.
And then we're going to go ahead and we're going to get create the AV fistula the next step. So obviously,
You can tell me
Uh-huh.
what kind of anesthesia do you have? Is it just verbal anesthesia or?
yeah, this is unbelievable. We've got, again, our nurses here, especially Liz and Reka, are specialists in anesthesia, and they've done a great job in sedating the patient. He is out. I mean, to the point where we were actually concerned that he was not breathing well, so we had to make sure that he's awake and all that. So he's good. He's sleeping.
I thought I saw a big sledgehammer at the back. You gotta hide that sledgehammer.
All right, down with the tourniquet, guys.
You're 014 from the top and 018 system from the bottom.
Well, no, we're just tracking the slender sheath in, so we need a stiffer wire here, Jose. So the next step will be creating the fit. Yeah, so right now what we're going to do is once we get the sheath in, we'll do a venogram and see how close the vein is to the. Let me get a dry one.
Yep.
How close the vein is to the artery, and then obviously Stephen will talk a little bit about that as well. Oh boy, there you go, we got it. Okay.
But we're going to switch to Grand Slams, like 014 wires for the actual crossing portion.
A little spasm here. Oh, okay, senor, lo siento. Okay, I'm gonna leave the wire up.
Yep.
So we're gonna leave the wire up. We're gonna give we give a cocktail now, guys. We give nitro and verapamil and all that. So that'll go in right now. Our ACT is 350.
Flush.
This is how much nitro? This is the cocktail.
No, this is 100C for.
Okay, give me some verapamil.
Verapamil blacktail.
Okay, 200 of nitro.
2.5 of rapamil.
I'm gonna give the whole 2.5 of verapamil in. Is his heart rate is okay? Yep. All right.
Tourniquet's down, right?
That's 56.
Yeah, I'm gonna go 1.5. I'll do a half the verapamil. And then,
That's a good question. Do you leave a tourniquet on the thigh so it stays in the leg? Otherwise, it goes right up to the heart, right?
yeah, right now the tourniquet is there, and I'm just letting it dwell in the sheath, Al. I'm not flushing it. I'm just dwelling it in the sheath. So yeah, you're right. It could go right up to the heart, but right at this stage, we went down with the tourniquet because we have to do a venogram here. So the next step will be hitting the venogram. So we're gonna go figure out, and this is where Stephen talked about high and low DVA, and I guess we can talk a little bit about that here. So I'm gonna do a venogram. Where's the die?
Contrast.
So let's go DSA here.
DSA.
Yeah, you're on DSM.
So I'm just
Is
gonna.
that a single or double injection? Just a single injection.
Single injection because you can see my catheter there.
The tourniquet is down now.
Yes.
Tourniquet's down.
So that's your vein. It's massive. It's a good
good.
sized vein. So now we're going to, if you want, so you can see it's right on top of the artery. So we're great here to get through. So the idea here would be, well, you know, how we want to, now we're going to come from above. So see, there's my sheath. That's a great representation. There's my sheath and there's the vein. And now we're going to go ahead and show you some of the equipment while Stephen, after that, Stephen, you could talk about where we should enter. So David, you want to show the equipment?
Sure.
So this is some of the equipment that we use. So can you focus on here, AV team, please? Yep, you got to step a little bit forward as yet. There you go. Okay, go ahead.
This is the first equipment is just kind of a snare that we use in order to help, you know, facilitate the AV fistula. It's just got a simple 2E system, pull and push. Very easy to flush, very easy to prepare. The other set of systems that we have is essentially the valvulotomy. Once again, very simple push and pull system, screw, flush in order to prep the system.
And it's a front cutting valvulotomy. I know Stephen went over it with you guys.
And finally, we have the actual lymph flow device that helps to create the fistula. Once again, very simple flush system.
Take it out. You can take it out. Show them.
Okay.
Yeah, show the needle. Cause
Show the needle, yeah.
Okay, we do have, we always have physicians asking questions about what's the difference between this and an Outback.
Yep.
So this device was originally designed from the Pioneer catheter. And in addition to that, the needle comes out 1.2 centimeters out. So that's a very, very long stretch. I think it's 1.2 or 1.1. So that has a real kebab in a 90-degree angle. It's not a re-entry device. So you can really hit things that are pretty far away. And it's a pretty aggressive piece of kit. It's actually 6 French. And I think a new version is going to be.
You can show the valvulotomy
Yeah.
too.
Yeah, it's like an Outback on steroids. When we used to do it off-label before lymph flow, but this needle is much better for crossing. And then this is the valvulotomy. So it's like PK mentioned, it's forward cutting. I'll bring it down here so you can see. And it tracks pretty well. So we'll use that as well after we create the fistula and everything.
So the thing here, I think that one of the things, it has to be an antegrade access. You know, up and over, it definitely is not the way to go. Trackability is impossible with this device. So it's got to be an up and over. And even with this level, you can see here, that's why we put the sheath into the anterior tibial artery. So now what we're going to do is our ACT is 350, so we're not going to give more heparin. So now we're going to go forward with the snare inside the posterior tibial vein, right?
Yeah, we just got to switch out for the 014 wire.
Right. So we're gonna get a vert tip catheter. Again, everything we're gonna do, it's we're not gonna lose access, guys, because there a spasm occurs. So we always do it catheter-based exchange. So we're gonna put a vert tip catheter in to the vein and then exchange out the wire. I mean, we've gotten into trouble in the past by pulling the wire out and trying to re-enter and doesn't work. So we'll just go with the get a vert tip catheter. Yep, there it is.
Right here.
Let's load it on this. So again, just deliberate steps because you know, anything can happen, obviously. So it's kinked. The vert tip is kinked.
So at this point, are you looking at the wires now to decide where to cross, or are you doing proximal versus distal, or kind of what's the preference?
So Stephen, what would you advise? Obviously, here we can do a distal DVA. We've got a healthy AT coming all the way down. Obviously, you don't want to steal from the donor artery. So, I mean, at least my concept, Stephen, and it's just my concept is, if we want to keep the donor perineal and the donor PT, we want to go ahead and go as distal as possible. But then, if we go too distal, the pressure head is not good either. So, how do you gauge what you're going to do?
So, we're definitely going to be putting a covered stent that is conical in nature, and that covered stent is 6 centimeters long. So you definitely want to be
David, flush the
origin, right? So you're probably looking at
the pigtail
around the So 6 divided by 2, so that's about 3 centimeters from the AT origin. So you probably want to be
Push the
around
UF.
Yeah, fresh
maybe
one.
No,
about
you just have to
Fresh
press the button.
centimeters on the ruler. So that's
Floor.
like midway. So that's a straight portion of the artery as well. So that allows you to take a look at where the wires are. So you could orientate the two wires so that you get maximum separation. When you get maximum separation, basically it's like an outback. You take the angle out of the way so you know that you're in full lateral projection with the device. You know, so I would probably say somewhere around 18 or 19. If you can get an angle where the two wires are maximally separated, that will make it easier.
So here you go, Stephen. This is probably the angle where the two wires are maximally separated.
That looks good.
Yeah.
So we're like at 16 or?
Well, probably at 18 because the covered stent is 6 centimeters long.
Okay.
You want to have half of that in the artery and half of that in the veins. So you want to make sure that your covered stent doesn't prolapse into the TP, into the pump.
The
I
transition is midway, 3 to 6?
Yes. 3.5 to 5.5.
But it happens in the middle like an acute
Middle,
or
yeah,
is it
2
taper?
plus 1 plus 2.
Taper, I can show that to
2
you.
plus
I
2
have
plus
that.
2 plus 2, right? I can't remember. That drawing came out on a napkin somewhere.
Ready, bro?
Uh-huh.
So we're going in with the capture device here. We're gonna drop it a little bit higher than 18, so right there, and then you're gonna see Ajita's gonna deploy it.
Yep, just gonna open it
Go
up.
ahead, brother. Talk about it. Yep.
So just you just unsheath it basically, and it opens up.
So can everybody see it? I'm just gonna dry cine. I'm just gonna dry cine so everybody sees it. Oh, sorry. Yep.
You back up one a little bit.
So there's the dry cine. Oops, sorry, we got to shutter in. Apologize. Bad angiography there. So there you go. So that's the dry cine. Now you can see why I have my sheath in. Our Grace, who's always with us on these cases, was worried about the angle. So now I'm just going to go AP, and I'm going to track the needle in, or the fistula creator in, sort of the outback that Stephen was talking about. So you'll see how it's actually pretty slick, but I think the worry here is that with that bend, here you go.
You have to be in the strict portion of the 18.
I'm sorry?
You have to be in the strict portion of the 18.
Probably a good idea is in the straight portion of the AT because
It's a wet one.
yeah, I mean, certainly that covered stent would sit a lot better in the wall of the artery. So I think it's probably a good idea to be in the straight portion of the AT. And you want to make sure that the covered stent doesn't collapse into the pump field.
And the reason why PT vein was not, says here's because of,
Well, if we take it from the PT artery to the PT vein, we'll lose the whole PT, which is supplying fluid. The backup option would be possible to run from the peroneal artery to the peroneal vein, which connects with the lateral plantar vein south as well.
So PK, anterior compartment, you worry about a compartment syndrome as opposed to the posterior. So any tricks to suggest what you say you don't miss?
I mean, it's pretty intuitive, Al. I mean, it's you'll see when we fire the needle, it looks very violent. I know all of you guys have done P-tabs. It's not as violent as the P-tab needle, but clearly, you really want to try to engage the cage. So you can see there's a lot of venous stasis. We'll flush that, and you see it's going to track in there. See, that's I think the advantage of getting this into the artery helps. And you're right. I think it is a worry, Al. You could clearly create a compartment. There is an issue there, but I think if we're extra careful here and do it in one shot, I think it'll be nice. But we'll take a look, see where it goes. So right now we have the Grand Slam down, Al, and that's the one supporting the needle catheter. Obviously, like an Outback, you can see here it has another entrance for another wire, which is what we're going to do. So we're going to need either a Grand Slam or a Spartacore, whatever your supportive wire is. The idea here is that you want to have through and through access to be able to track your valvulotome down. And Stephen, maybe you can talk a little bit about that. And what are your tricks, Stephen, to hitting this at the first shot?
Backed up.
Yep.
Full lateral position and be patient. And try not to hit it too many times. So I think this is nice. I think we get a good projection. Maybe. Yeah. So at what level are you thinking of crossing? Is it around it? The 15 or the 18 or?
No, we're gonna pull the filter. I mean, we're gonna pull the capture device down here. I'd like to enter on 18, right about there. So I'm gonna move my needle catheter down a little bit more. Can you tell them where the needle fires, Stephen, so they're also aware of it? Can you rail my
Yep, got it.
If you direct, you can actually see the needle a little bit above.
Like 19, right? It's at 19 or something.
Yeah, no, it's.
Okay.
Yeah. This is the needle. Oh. This is the marker. So the needle.
Bring the
fires
catheter down.
directly opposite the marker.
Okay, good.
Yeah.
I think that's pretty good.
See, say that again.
Thumbs up.
Oh, sorry.
Pull back a little bit, or
Yeah, I will.
Isn't it down? It might-
No, you're right. It's at 19. Sorry.
Oh, okay.
It's at 19.
So you can almost see it off the wire. Is that right? You're saying,
Yeah, so
Stephen?
this is
Oh, they can see the needle.
This is the marker. This fires directly opposite
That side. So you just keep that needle to that side.
So I mean, we like to keep this marker in a single line, just like your outback, and then this will fire in this
Right,
direction.
gotcha.
So it'll literally go probably right here.
Gotcha. So use the marker, not the needle. I was looking at the needle. I guess, but just use the marker.
That's a good spot, PK, and I was telling the rest of the guys. Oh,
Yeah, it's good.
Yeah.
This one.
that I mean, how do you? I mean, when we do a re-entry, we're a little bit careful. We sort of go forward a little bit, but I just like veins and putting in PICC lines, I let go right through the vein and pull back.
Well,
I tend to like to do it, but
So what I'm gonna
really
do?
with the snare, you don't really need to. You could push the needle forward and feel that you've hit the snare, and try to advance the wire beyond. So the snare keeps the vein open so that the wire can go south.
So you don't have the T and L's that you have with the
just-
Outback.
It's a rectangle. So you're able to, instead of a T and L, it's a rectangle, so you see a single line versus.
So Stephen, you showed a lot of pictures this morning, a lot of calcium. Do you care whether it's there or not? You find a soft spot, or you just shoot through?
This needle does it.
Okay,
So-
you don't worry about it. In other words, you go for the spot you want to hit, right?
You're in a very small space, so this catheter has a lot of backing. The only way is forward, so it'll go across. Yeah.
So Stephen, again, Ajit, any comments on our tricks? I mean, what are your thoughts?
Yeah, so I think it's a pretty strong needle. So we've used it through calcium without any issue. And then I think just the angle is key, because you really want to get, even if it's like super lateral or medial, you want to get a good oblique so that it's really right to left, left to right, or whatever. So that way you know you're kind of oriented in the correct direction. But yeah, no, I think the needle is very good. And then sometimes you do go through and through the snare. So you can see the end of the needle pretty well when we deploy it. So I like, sometimes you can pull it back right into the middle of the snare and then advance your wire.
So if you guys are okay with it, I'll advance it slowly. I mean, it looks pretty reasonable. Let's see. I'm pressing the button here.
Is that the key slow, PK, or do you just fire it?
I'm just coming slow here, and let's see.
Yeah, you can see. Yeah.
I mean, I don't know how that looks. I'm going to give a wire, and then
Here's your wire.
I'm just going to go with a wire here.
The other thing you can do is, can we go floral? Is we can pull the snare back and forth, and if it's caught the needle, it should get caught.
Outside it goes.
So-
it actually goes more. Because it's a limited space.
Yeah.
Probably the
Yes, you caught it.
I don't think, yeah.
No?
No.
Okay.
So I don't think we have it, because I'm moving the snare back and forth easily, and it's not getting caught on the needle. So I don't think we're in the vein, but we'll see what the wire does.
So I'm just going to pull back the needle a little bit, the typical Outback trick, and then see whether it just pops in. And I think Ajit is right. I don't think we were in it.
Give you a little.
No, we're not. We're not in it.
That look right.
No, it's not going to go, Al. See, it's not behaving well.
Maybe PK, if you want to change the angulation, see if
Yeah.
you get a bit bigger separation between the two.
Yep.
Maybe that might give you a better idea.
You want to try this one?
Then
try
you can rotate the arterial catheter
Look at that.
That's too much.
the other way. Yep.
Yep,
That's it.
I'll fire
So
here.
you pull back the needle.
Yeah, of course,
pull
yeah.
back the needle.
Now, Ajit?
Okay, pulling on the snare.
Nope.
No, I don't feel much resistance.
So I'm just
I
going
think
to,
the arterial catheter spun a little bit when you had the deal.
Yeah, it's turn front to back.
now?
That looks good.
Now we're in. Nope.
I don't think so.
So I think it's more anterior.
Yeah, let me. All right, that's where you were before. But yeah, it's either got to be a little anterior or posterior.
I'm trying there.
Yeah.
A little pull?
No.
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 No, you're not. Yeah.
Yeah, maybe there.
So Ajit, sometimes what I do is I inject some contrast into the vein. So
There you go. Now you're in.
You've got
Yep.
it. Yeah.
Yep.
right?
Okay.
Yeah, I'm
Good.
catching something.
And he felt it.
Yeah, you caught, yeah,
I'm gonna pull this back now.
just the extension.
So Stephen, you were saying,
Yep,
That
you got
looks-
it.
inject contrast?
Yeah, so what I do is sometimes I inject contrast.
No,
at
I'm
the
through and
vein.
through it, Jit, or what?
I can try. You want to reduce the needle, and then I'll try capturing the wire. What were you saying?
Yeah, sometimes I inject contrast.
Yeah,
into
no,
the
I got
vein,
it.
and
Uh-huh.
you can actually see the needle poking on the anterior surface of the vein. Oh,
Yeah.
yeah.
Is it going?
Yeah, I got it.
Yeah, we're in.
So you're gonna.
Great job.
I'm trying to feed it. It's very tight, Ajit.
Yeah, let me pull back. I think I probably have some slack here.
Yep, it's very
Guys,
tight.
what wire did you say you used for this?
Grand slam.
Grand slam. So it's
Does it matter?
yeah, it's best to use an uncoated wire because the coating could share with the needle.
You
So
follow
I
us
would
down,
use a
David?
Sparticle. I'm not familiar with Grand Slam.
Grand Slam is not coated either.
It's not coated, yeah. So
We have a accessory checklist that has all the recommended wires on each one of the steps that we can provide.
And that does not come with the
Platinum
kit,
plus
right?
or
By the wire.
sorry, use also platinum plus that is.
But again, those wire recommendations are there because in
Anything.
Grand Slam is
$6,000 for that wire over there.
Okay, you got it?
Yeah, I got it now.
Okay.
Mosquito?
I use whatever they.
Okay, you got it?
Yeah, but one sec, I don't have a.
A little bit more?
No, I got it. I just gotta take it out.
The vascular surgery always say, give me what I want.
You're pulling the wire while,
Okay.
Feeding the wire, yeah, so.
pulling back on the,
I got it.
Okay,
Feeding the
cool.
wire and he's feeding the wire in so that the snare doesn't slip out.
Can you come up to the AT? So-
Because they're pretty floppy wires.
So now what we're going to do is we put a clamp on the outside wire, so we got the old Safari, and now I'm just going to I've reduced my needle and I'm just going to pull this out. So all these are going to come out, all
We can
my
get rid of
wires,
this
my
wire.
needle, and obviously Ajit has the other wire tracked, so it's going to be through and through. So I'm taking out my my entry device here on this end. Okay, and the entry device is out. Michael, can you come here, please?
Yep.
Thank you.
The other thing that. Sorry.
the wire while the needle was still through.
Sorry, bro. There you go. You can take the entry device out here.
Just like the
Needle's back.
outside, you pull it back and you walk it back. You walk it back, but in this case, you try not to lose the wire, so you have a bit of forward push in the wire
Okay.
as you're walking it back.
So you have enough support.
Okay, balloon. Now we'll do the AV fistula.
Yeah. What do you want to do? 2.5.
So
right?
now
Guys, I'm
Stephen.
looking at the shaft on this needle. What length sheath are you using in there? Because I saw you had a little of a loop external. What are you using? What length of a 7 French you have?
A 55, Al, because we wanted to go into the AT. To give us pushability. So now this way we were worried that because it was a 90-degree angle, as you remember my popliteal shot, it showed that there was a 90. So Grace was worried that it wouldn't quite make the turn. So we just tracked a 55 centimeter sheath into the AT, and now we're gonna create the fistula. So what balloon do you usually do, Stephen?
I would go with a 3, just for start. It is a
3-0?
5 millimeter vein, looks, so maybe just a 3, and then I think, what are you thinking in terms of the next step? Do you want to connect it with the foot, or you want to,
Well,
because the.
what do you mean? Well, don't we want to create the fistula first, don't you think, and then work, or what are your thoughts? Yeah.
Well, sometimes when you create the fistula, it could bleed in the anterior compartment, so depends on how robust those veins is. Maybe it would be a better idea to put a catheter, maybe dilate the AV fistula with free balloon and put a catheter and wire into the foot.
Oh yeah.
Once you wire into the foot, then you could go ahead and do. I'm not sure if there's a lot of room for the valvulotomy in this case because you're probably gonna need to scaffold all the way into the foot. But I don't know. I mean, I have limited experience in the 8 feet.
Is the balloon is a non-compliant balloon or semi-compliant?
Non-compliant balloons probably. But do what you want to do, PK. We're with you whichever way.
Well, I can be honest with you. The two we've done, we've actually ballooned the AT and created the fistula first. But I like your idea. I think Ajit also will agree. We'll see if a catheter will track, and if we can get it into the foot and create the fistula, that'll be wonderful. And then we can do the stenting. That's actually a nice idea. I don't know if you guys want us to try that. I mean, obviously we're all learning together, so we can try that.
The only caveat is having that through and through wire for the support and trackability is sometimes nice because I'm putting like tension.
Yeah, right here.
Because I'm putting tension on both ends of the wire, which I think helps track the balloons and everything.
I've had a scenario where I balloon the fistula and the veins rupture, and then what you have is massive bleeding into the calf. But in this case, I think the risk of it is pretty low because you've got the AT jammed in, with a sheath, So I think either way, it's going to be
So you can see where we created the fistula, right there with the little waist. So that's kind of the idea here. There. So,
You're occlusive with the 7 French anyway, right?
absolutely. Yes, we are.
Yeah, that's a good point.
Yep.
We are.
So normally we use the ruler, but sometimes what I do is to mark the area of the crossing so that I'll put the covered stent, I'll put a needle on the skin, and I stick the skin so I mark where the crossing point is.
I think, yeah, the ruler, yeah. Oh, I see.
So across at 19, I guess.
Yeah.
19, I put it on the skin so in case
I fellow pulls the ruler off the table.
All right, I'm up at 20 atmospheres here.
So we're up at 20 atmospheres, still hasn't cracked.
Yeah. What is this, PK?
It's a coronary 3.0 balloon, high pressure.
NC or SC? Yeah.
NC.
That's 22.
The 22 atmospheres now.
A little better.
A little better, but we got to crack this thing.
Well, something's going to crack.
Looks better now. Yeah.
Stephen, have you ever done a cutting balloon or something in this area?
Yeah, I have done it on very calcified vessels, but usually high pressure non-compliant balloon usually does the trick, So you could use a coronary scoring balloon or a flex tome or one of these things. Why not, But
well, we could do the Wolverine down and go up again, brother.
Coronary-wise, what do you guys use for these recalcitrant lesions in the coronaries? That's the
Usually the Wolverine balloon, obviously an NC balloons are great, but we can use a Wolverine. Wolverine balloon is a great balloon. We can try that. If it's calcified, you could try a shockwave if you need.
I think that opened up.
Spin the C-arm a bit and get a different projection. Is it fully opened up? It looks like it's fully opened up.
Looks like it.
Yeah, I think it looks pretty good.
Yeah.
All right, I think we're good.
You use a 3.0 balloon?
Down?
In general, yes, 3 or 3.5.
So what I'm going to do here, guys, I'm going to try to put the inflated balloon through, and you see it's very smooth. So I know that this fistula is quite healthy because we're able to go right through with the balloon. So now I think, I'm going to walk this balloon out, and then we're going to go ahead and
You're going to predilate the vein?
Predilate the vein, yeah.
Is there any utility in taking a picture then if you're worried about extravasation or?
The balloon's on the floor. You can drop it. Why don't we just take a little dive shot? Yeah, with that.
Can you set it up?
Yeah, Stephen, with that. Prep it up, just obviously.
So I think, Stephen, you scared us a little bit, so we're going to do a picture now to see if there's any extrav.
Yeah, Stephen stepped out. He went to use the restroom.
Okay, well then Al scared us a lot with the anterior compartment thing, so
just trying to look out for you,
So we're just going to give a little dye here. Okay, just enough to see, guys. So this is the fistula from the AT. Okay, no extrav.
No extrav.
Okay, good. So no extrav. So it's a pretty big vein, Al, as you see. So that's
nice.
So it's a
So
big.
you take the from above?
No, from the sheet, where we were.
Yeah, from above, from our 7 French sheath.
Yeah, let's do it again from here.
Looks really nice.
Yeah, so this is there it is. That's our fistula right there.
Oh,
So no extrav. So I think we can balloon this, and you see the size of the vein, Al. It's a big vein, guys, and I think we're gonna go with a balloon now. Grace, what do you recommend here? 4 or 5? What do you think? Give us a 5.0 long balloon here, guys.
Perfect.
5.0 150 is good.
You can see the fistula. It's nice size. Your balloon did a good job with it.
Yeah, I mean, it doesn't seem to be extravasating around. I think we'll be able to do this quickly. So we're going to balloon the 5. We're going to get through. The question is, I don't know whether Stephen would run the valvulotome before ballooning. What do you think, Grace? Run the valvulotome before ballooning or ballooning first? Okay.
Yeah.
So, to me, in this kind of vein, I think...
For you, Steve, did valvulotome first or balloon to...
Right. So actually, since we're going down the AT and we're lining it with covered stents, you don't really need a valvulotome because you're going to line it with covered stents anyway.
Right.
And the valvulotome is in general used distal to the covered stent.
In the foot,
but
yeah.
In this case, because the dorsalis pedis vein is probably very small, I think you could do quite a bit of damage with the dorsalis pedis vein if you're putting a valvulotome in. But I would say probably go ahead and put it down the AT and just show them gently what it feels like when you push the valvulotome. I think it's, since the size of the vein in the straight portion of the AT is quite
You see our sheet? You want me to pull the sheet back a little bit?
Actually, why don't we run the valvotome? Walk this out. Like, give us the valvotome so we can at least show them how it looks in this case.
Do you want to? Okay.
You
Do you
can
want to
pull
just
this out.
balloon it so the track's better?
Let's try. Let's try without ballooning it.
Okay.
Yep.
What's a 5.6 or
It's a 4 and 5 cylinder. 4 5.
So what do you have right now that in the that's the valvular tone?
No, that was the balloon. We took the balloon out. We're going with the valvotome because I want a JIT to show you how it looks when it's open, and I'll just push it. Normally, like Steven said, in the foot, we're pretty violent with it. I always tease Steven that I feel like a surgeon because I'm able to push hard, not be afraid, and like a cardiologist usually is with these things. And it's an incredible device. I mean, I think it's really the game changer. When JIT and I were doing the off-the-shelf PDABs, the hardest part was lysing these valves. And obviously with this valve, we used to use coronary cutting balloons, 4-row cutting balloons, and pull them back, but nothing seems to work like this valvotome, and it's really phenomenal. So it's a forward cutting valvotome, and we'll show you how it looks. I'm going to take a little distal. So there's the valvotome already there. Okay, Jet, you want to just open it and you want to show them? So I'm going to mag up for a JIT.
This is your favorite part, PK.
I know.
You love
I
it.
know, Flora. So there you go. There's the valvotome.
So I just opened it. You can see it open up pretty well.
Get a fresh one.
So sometimes when the vein is small, it doesn't open up as well, and you can predilate it. But either way, and then it's a forward cutter, so I'm leaving it open and then just pushing it forward. You can kind of, just like you guys are vascular surgeons, you kind of feel the resistance as you're cutting the valve sometimes. And same thing with this. You kind of feel
pushing it out. Pushing. You
Yeah.
can be fairly violent with this thing without causing damage because if you can see, the blades are at the back end, and once it catches on something, the lantern or the thing actually collapses down.
So yeah,
And then so this is a 4 French forward cutting valvotome that has a braided shaft. And
I think it's good, right?
yeah, that's good.
Good.
Try to get over there.
Close it.
If you really wanted to, you can actually inject contrast with the valvulotome. The valvulotome has a 2E on the side, and you can use that to inject contrast and then use that to cut and something. So it's a couple of
So you use the valvulotome distal to where you're going to cover the stent.
Yeah.
And it's just one size, Steve?
Yes. Yeah. So if we were going to land the covered stent here,
There you go. Beautiful.
I would
DSA, you're on
use
DSA.
the valvulotome distal. So normally I would have the wire right across the loop first, and then have the valvulotome under the foot and clear those valves before I put the covered stents in the loop. Under the foot. Because there's always a valve under the foot in the posterior circulation. So
No, it looks pretty good.
That's
Up
good.
into that. Yeah. Okay.
So you can see it.
As I mentioned, I will get the wire right across
You
first,
just pull it out. Yep.
and then do the valvulotome distal to where the covered stent is, and
got it.
then put in the covered stents right in. Because the moment
So-
you put in the covered stent, there's forward
Take the
flow.
balloon now.
So my question now, Stephen, do we need a cover? We need to balloon. The vein is huge. Why not just put the covered stent in first?
I generally like to get the wire across the distal access so that I can have assurance that I'm beyond the foot. And then after that, put in the covered stents right at the end, How long? Yeah.
What about-
What does he mean by the distal access?
Like he wants us to go around the loop now and then put in the cover stents.
But I think we should just go with the catheter and do that then.
But the only question is that through and through wire, I think, helps with tracking the stents.
That
That's
is true. With the right angle, Stephen, I agree with the JIT. I think with the right angle, I think put the stent first because otherwise the tracking the stent may be a problem without the through and through wire.
That's fine. Go ahead and put those stents in first, and then.
You're at my sheet. You're in the sheet.
Yep.
Okay, right here.
And you work from fistula forward or distal backwards?
Sorry.
You fistula forward or you start the stent, is it not, you have a long segment stent?
So we generally deploy the stents from bottom up.
Bottom up.
Yeah, bottom up. Stack those things up.
Yeah, just so it doesn't catch the other stents. I think that's a better idea.
If you put the conical stent in front, the next stent that goes beyond that to push that conical stent distal. So I generally like to. So tell us, PK, what size of balloon are you using?
It's a 50150. I'm going to measure, obviously, because I have my sheet in. So again, the vein is quite large, so we're
no
just
real
going to go to
waste.
nominal here. There's no real waste. So 6 is nominal, so we're going to go to nominal. And then we're going to now show the fistula, and we're not going to go too far, because remember, we want the tapered stent. So 19 was the fistula. So I'm just going to stop right about there, 21, right? I think that's reasonable. Or should we go to 20?
Yeah, I think 21, 20.
Maybe right here.
Because it's a big vein all the way up, so.
The other thing to consider is if you put the covered stents first, there is flow, there could be stasis within the covered stents if you don't have it running into the foot already. So, I mean, you have to do a balance between the pros and the cons. But generally speaking, in a posterior circulation, I like to have the wire across, do the valvulotomy, and then lay the stents. Because right now, if you lay the stents,
Stagnant flow.
it could be stagnant flow. But that risk is actually quite low as well because you have a sheath that jam into the AT. So that's going to cut off the flow and that's going to reduce the risk of having stagnant flow within the covered stent.
No, when you say you wire
Okay.
across, what do you mean?
From the DP vein,
You wanna
you
pull
have the
that?
wire past the sheath.
Yeah, just waiting for it to
DP
deflate.
vein into the lateral plantar vein.
Alright, so I think we're ready to stent.
Okay, so listen, I mean, look, we're anticoagulated. We're at what 315. We're going to give another 1,000 now, so we'll be fully anticoagulated in the 350 range, and then I think we're going to lay the stents down. You know, I agree with the JIT. We've had trouble when we haven't had through and through wire to track these stents, and I think in this situation with the 90-degree bend, I mean, I know it's not a great, you know, how can I say, a risk to potentially have a clot within the stent. I don't think we'll develop it. We'll keep them fully anticoagulated, and we'll work fast. So we're just going to go with the stents.
And then just to add to that, I think it's also, especially if you're doing a distal fistula, tracking the stents in through the artery, especially if there's calcium and disease, can be challenging. This one is thankfully proximal, so we don't have to track it through the artery, you know, that much.
Yep.
You mentioned the plantar vein valve
I don't know.
in the.
We can do 150.
Let's just do 150.
Yeah, first one we'll do 150.
Perforated to go to the dorsal,
No,
or
it's in the mid portion of the foot. It's always in the mid portion, right?
it's on the bottom end?
There's one valve at the ankle here, one valve here. Sometimes there's one.
You know what you could
before
probably
it's
do now? Walk the sheath back, and then take a shot through the sheath. See the
Oh,
arch
yeah.
better.
Yeah, it's probably going to be occlusive.
You want to do that?
Yeah.
You can try.
No, it's right
I don't know if we'll see anything.
Okay.
Because I think it's occlusive, you know?
No problem.
Because he's feeling me pull this back, so I think
Okay,
it's spasm.
perfect.
Should we tell them about the hawk that
What's
we
that?
did? Should we tell them about
Yeah.
that?
So
It's a stent is 5'5". Yeah.
So the
so
So-
Ajit is going to tell you a funny story.
So yeah, the valves, especially in the PT, we've kind of struggled sometimes to open them. We've used like high pressure balloons,
Three?
they pop. We've used the
on this way.
valvulotome,
Wait on the
but
top.
especially one right by the ankle can be really tight. So PK is an innovator, and so he figured, why not just put a hawk device in there and see what happens?
So we did a silver hawk. Yeah. So we were.
But it worked.
It worked.
Can I get a fresh?
It cut whatever the valve was.
Oh.
Because that's because you haven't taught him to cut from the skin.
That's right. I wish yeah, that's funny. So, all right. I always tease Al, like, I really want to
The
be.
communication between the DP and the lateral plantar, can that vary from person to person?
Pretty consistent within the first, very similar to the arterial circulation.
Same as the artery, right?
Yeah, but the only difference is that the superficial vein, superficial medial marginal vein, so this great SAF vein, the superficial medial marginal vein goes
Wow.
forward.
Not going?
and
Not
puts
going.
back And joins the.
There you go.
the
So,
trifurcation
yeah,
to the
I think we
DP
needed it.
vein.
1 sec.
So there's always superficial vein that goes and hooks backwards. Yeah.
Okay, so guys, I had a lot of trouble pushing that stent through. So I'm glad that we didn't lose the through.
At what level, PK? Anastomosis or just through the
But,
valves, the legend valves?
No valves. It was the bend of the AT. We did not want to go. I pushed it quite hard. The patient had pain, and then when I pushed it through the anastomosis, the patient again had pain. But now we're through. The question is, Stephen, how low will you go with this now?
Where is your puncture point?
The puncture point is like down here. It's at the bottom of the screen, and the sheath is like somewhere right where my finger is.
I think above the ankle joint is fine, and you take a more flexible stent distal to that.
Okay, I'm going to stop here.
Right now from below?
They put
The-
a 4-5 slender.
Yeah, 4-5 slender, and the sheath floor for me.
Below. Below.
Sheath ends right about here, I think.
Okay.
Is that the puncture point, Ajit?
No, almost. The puncture point is right off the screen.
You can move the sheet. You can
I'll
move
pull
it
it
down.
back a little bit more.
Are
Okay.
you able to bring the covered stent a little bit more distal, or that's as maximum as you
I can go down.
Oh, nice.
Yeah, the puncture point's
The
like
point-
right there.
The
I'm
point.
thinking what's the best stent to go across the ankle, guys, because we don't really know.
I
I
think
think that it would be a fair location, just past the ankle, and let let the next stent take flexion.
So you want to go past the ankle?
In the anterior system, I don't know.
No, no. So over over here, Stephen, I prefer not to go past the ankle. I'm going to stop here. I'm going to have a jit. I'm going to have a jit flex the foot now. Flex the foot, brother. So I want you guys to see whether that see the stent is not bending now. So
You want to do that lateral, PK,
sure,
so we can
absolutely, absolutely. So this is another trick I think is important to make sure you're not bending the stent, especially the covered stent. See, there's no action on the stent here, so we might use the supera, you know, in that area. But obviously Stephen has taught us about alluvia, so I think at this stage I'm going to have a JIT deploy this. So this way I'll just watch the sheath as he's deploying it. So this way we know that. Actually, why don't you put this in front of you?
See up north where the proximal portion?
Yeah, I'm gonna. David, can you show above, please? So you can see above. There you.
Because it's dorsalis.
So we've got plenty of room here. There's a 150 stent where our fistula was at 19. So you might as well deploy.
Okay.
So we're gonna deploy. Show down, David.
Show me down.
So there you go. So we're going to be above the ankle. I'm going to put an alluvia distal, I think, in this case. So this is a nice deployment system. Ajit, you want to talk a little bit about it?
Yeah, it's just you basically unsheath it using the wheel here, just like similar to an alluvia. It does take a little bit for the stent to start flowering out, but it deploys fairly accurate.
5 times what?
It's a 5.5 straight. Yeah.
And the length?
Yeah, this is a 5.5 150 stent.
Now, why down at the ankle? Because of perforating branches along the way? Do you really need to go that down?
Well,
So-
if you don't cover the perforating branches, the blood will go preferably.
Yeah, I'm saying, is there that many that it's an issue, or?
Honestly, in the AT, I'm not sure. In the AT, I'm not sure.
Okay.
So we'll need another 150, you think, or?
But if we do get branches
Another
going back,
150?
then maybe options to coil it.
Or you think 100?
We need to go from 26 to 19. So yeah, 100, I guess.
There's a tremendous amount of branches there.
Okay.
but-
All right, 150.
So
So if there's no branches
Okay,
beyond that
150.
stent on this picture,
we
would you
don't know.
stop? We don't know, but I'm saying if there was no branches, if you do a picture, do you do a shot now? If there's no branches at the ankle, do you stop with the stent, or you still
We
go
need to
with
see that the distal opens up because this is the outflow for the whole stent. So
And then, can I get a 4.0 monochrome?
I would be quite keen to stent it because I know these DP veins are very small. So you could have it end up with the blood going into a superficial vein and going back to the heart,
never getting,
not getting the flow going forward.
so you won't accept any branch, in other words, you don't want any.
Gotta go down.
250
So,
going.
Give me some facts about this stent. So this is in a sense, it's a pin and pull, but with a ratchet system.
Show me above, bro.
It's incredibly difficult to manufacture a covered stent that is 7 French compatible with a 150 length platform. So the stents that you're familiar with are the Viaban, and the Viaban.
That's good.
Yeah, that's a good spot, PK. Maybe up to about.
Because
where are you at?
Because we got the 3.5 tapered stent, right? So we
How
created
long
the
is that
fistula.
stent?
We created the fistula at 19, Stephen.
60.
Yes.
Yeah, that should be plenty because it's a 60 millimeter stent.
Is this okay? Or you want me to come back
That's a
to?
good spot.
Yeah, I
Maybe
agree.
come back to 20. Just.
That's what I'm going to do. That's what I was sensing too, right there. All right,
Yeah,
It's another 150, Jose. On 6 150. Yep. Go up. Is it 6 or 5.5?
It's a
5.5.
5.5 150, not
And
6.
Are you thinking of a 4 mil stent on top or a 3.5? What does the size of the proximal AT look like to you?
It was about a 3.5.
Right. So 3.5 60, right?
Yep.
So that's a 3.5 to 5.5 tapered, 60 length.
3.5 60 up, Grace. 3.5 5.5 60. Thank you.
291.
291. Give another 1,000 of heparin, please. Thousands in. Okay, excellent. Well, okay. So
Okay.
now we're going to go with the 3.5 proximal. Okay.
So how do you guys once we do this, how do you manage the pedal sheath, you take it out before you deploy the stents, or what's your, what do you recommend, Steve?
I mean, I think generally I would put a 4 French catheter and wire past the sheath before I pull the wire from the top. So
Uh-huh.
I
Got it.
like to
Yep.
make sure that I have access. So what I would do is I would put a 4 French catheter above at the top, go distal to the stent, try to wire past the distal stent first. If I can't, then I will pull
Think that's good?
I will pull the sheath back.
And a little
and
more, I
maintain
think.
wire access.
Yeah.
Once I get
Oh, just
once
a
I wire
tiny
past
bit,
it, I'll
yeah.
pull all the other
That should be
wires.
good.
It's best to get past the sheath before you pull your wires.
So
Yeah.
So you want to actually get deep and into.
Deep into the put all the way across
From up, yeah, from
from
above.
above. From above.
So Stephen, what do you think about this?
That was good.
So that's,
Yeah. You
I
wanna,
like it.
so it's from 22.
how far are you from the AT origin?
No, yeah, we're into the AT. I can give a little die. David, a little die
Yeah.
into the AT, bro.
AT origin, I think, is like 13,
We'll just
14.
get, 14 is AT origin, but I want to show you here.
So you're at 16 to 21, I guess.
Let's see. David's gonna give a little die.
About there.
Are you giving die, bro?
Is it going through? Which?
No, you got to give die through the sheet here. This one. Yep, a little
What
die.
happened was the mid portion? Sorry, what happened was the mid portion of that stent? Nothing?
Little die.
Escape it, yeah.
That's the die.
Well,
Are you injecting from above? Or? Yeah, I guess.
Yeah, so it's occlusive in the AT. I think we're good here.
it's a
Yeah,
good spot because
Yep.
you've got a collateral that's
Yeah.
that's
let's go up.
15. Maybe you don't want to cover that collateral, yeah?
Yeah, so we're just gonna go right across it.
Your floor?
Just go ahead.
Yeah, I'm flooring.
So this stent is a little bit different from the others. This is a straight pin and pull. It moves quite a bit. So it's an old generation. Oh no, it's a ratchet, is it? Oh, okay, sorry. Like I said, it's been a while since.
Okay,
we've
let's
used
walk
an
it up.
on-label product.
All right, so now we're gonna
It's pretty nice,
So
right?
I'm not going to walk the sheet back yet, right? 'Cause
Yeah,
we
let's
might have
balloon
the
it.
alluvias. So now I'm going to balloon this. Give us a 5.0 long balloon. Now 5.0 200 balloon.
Yes, sure.
What do you want to balloon the proximal with? The 3?
Yeah.
Yes.
It really
Yep.
was 4.0.
Yes.
So
And we're going to do the proximal with a 3.5.
Coronary stent and-
Get us a 3.5 coronary balloon. 3.5 30. So we're doing a 5.0 200 a distal, and we're going to make sure we're not going to come into that tapered segment. And we're going to do a 3.5 in the proximal and create. Then now we've basically stented the fistula, and then what we'll do now is then go, like Stephen said, into the arch. So we're,
Could you take a look at a distal sheath? Are you getting pulsatile blood coming down? Just curious.
Let's see. Oh, we have wire up there.
Just open it and have a look.
not yet.
No,
Good. Good.
nothing yet.
That's out of the problem.
But our sheath is also occlusive, so it could be from that too.
We're occlusive up top, so there's no flow in this system right now.
So eventually we're gonna have to pull that back.
You're using an NC or so this is the part where you get a bit.
Show me above.
So sometimes you can give a bit of lidocaine from the sheath above.
That's perfect.
So what
We're
are you
good.
doing now?
You're all bit below.
We're post dilating.
You're ballooning across the.
No, I'm not at 20.
So this could be a bit sore because
See?
you're
We're down.
pretty much.
Oh, that's not that.
rupturing
Okay.
Yeah, we're good. Well, I'll if you want to go forward a little bit. It's okay.
Yeah.
That's not a big deal.
What size is that balloon?
That's a 5-200. Yeah.
So you notice where we stopped right before the taper. So the taper is still a 3.5. So this is a good place to balloon with a 5. Oh, yeah. Are we good?
But that's right there.
No, is that it? Are you sure?
Yeah.
Let me make sure.
I think so.
Yeah. Thank
Oh,
you.
you're right.
Yeah, you're still in the vein. You cross at 19, right?
Yeah, so we're right up to it.
Yeah, so we just want to balloon this open properly so all these stents are well expanded. So he's feeling a little bit of pain. We got our crack pain team on it now.
That's 8.
8, 10.
So the balloon is almost
12.
where you're crossing.
Yeah.
All right, we're at 12 down.
Use it at
5-200.
5-200 NC balloon here down. So this is a BD what is it called? What is this one, David?
Ultraverse.
Highlander. Highlander.
Yes.
part of the package or an external user? I don't have any, but that's 014, I'm assuming 014 compatible, right?
It's an 014. It's an 018.
It's 018, I think.
It's an 018 balloon, Al.
Okay. That's why I was asking.
Okay, give us a 3.5 balloon now. You can get rid of this.
So PK is not fully expanded, but you can come back and post dilate later on, right?
Yes, right now I just want to create a track for us to take our catheter down and make the fistula the next step, and then we got to decide the alluvias and things like that. So it's going to be quite a bit of work now. So the work's really just starting, honestly. It's because
How do you
this.
know if it's bleeding at the proximal portion of that taper stent?
How do you know what? Oh, Jose, I'm sorry, I couldn't hear you.
Bleeding around the proximal portion of that taper stent in the top, around 16.
It may be, but I don't think it's significant because we're occlusive with the sheath, Jose.
Another ECT.
We have like what, 2 centimeters, 3 centimeters overlap?
Is it around this then?
Yeah.
Oh, it's
It's right there. He's
Yeah,
got it.
okay.
Pull.
I mean,
Got it.
it's a space.
Okay, so
I
not a
think
big
it,
deal.
yeah, and even if it goes, it's probably running to some vein distally. I don't know.
Okay. It's not an issue. Usually not.
But we used to put the proximal stent first.
Yeah.
And then when we ruptured the veins down below, we had a compartment.
Go up, brother.
So now we put the stent from the bottom and then we connect the top
I see.
only after
It's fine, I got it.
while doing a control rupture of the vein. So what do you have there right now, PK? Is that a
It's a 3.5 NC coronary balloon. We're going to 20 atmospheres on this one.
bust the move?
Huh?
No, bust the move.
Is it going up?
Yeah, I think there's too much air in here.
Where's
What-
that balloon?
It's too dilute, you're saying?
Yeah.
It's too much air, I mean, it's too much air. Hold on.
Oh,
Yeah, yeah, now we're going to go up. Yep. Good.
You said that's 3.5, right?
Yes, 3.5, 20 atmospheres.
What's 10? It's 12.
14, 20.
Yep,
that's
20.
20, down. And then we're going to go prox here. And right there, bro. Go up again.
This is trash.
Yep, 20.
Down. I'm going to come back slightly. Right there. Let's go up again.
The proximal AT was healthy. I
Yeah, it
believe,
was
right?
healthy,
Yeah.
but I just want to expand that covered stent there. It's still not expanded. Down.
Yeah.
Okay,
I
now.
think you're probably best to put a coronary covered stent at the top to make sure it flares because of, the,
Down.
this doesn't look like it's going to open up too well.
You said a coronary covered stent.
That's right.
Okay, give us a Navi cross now. So now we're going to go with the Navi cross. 018. 035, I mean.
Isn't that micro?
Up to
Was that?
16 would be a 4 or one of these things.
So we're going to go with the, okay, Dame, just give me a vert tip if you don't have it. No, he's got a Navi cross. So we're going to go with the Navi cross now and try to navigate the arch, which, so we're going to use the, with the cyan blue wire, is it? Which one do we like? Cyan blue or black? Which one do we like?
I can see blood coming down the bottom sheet. Is that right? Little trickle?
No, not yet. I mean, should we pull our sheet back and see what it looks like, or?
Yeah, you could now.
Just better to wire the foot first.
Yeah.
Yeah.
Oh, no, I mean the proximal sheath, so we're not occlusive. But no, it's not pulsatile, but I think the sheath is still occlusive from above.
You know, what I'm worried about is, are we going to be able to dilute with the alluvias? That's what I'm worried about across the ankle if we lose that proximal sheath. So I think these are the things you have to think about at this stage.
But do you think there's any utility in having like an arterialized vein to like cross through it?
Yeah, agreed. But yeah, I see what you're saying. So we get the pressure
distally?
head.
I don't know.
Yeah.
Just put aside continuous infusion. I agree with you, PK. I don't want to lose your sheath in there because if you hit that ledge in the AT, you're going to be suffering if you can't get it back in.
That's what I'm so worried about here, especially. Okay.
Yeah, and
So
just put like a continuous pump infusion. Keep flow going through that thing.
so here, so now I've got the. This is my what is it called? Navicross. I apologize. My Navicross, and now into the distal. So now we're gonna have to try to lose this wire, right? We're gonna have to lose this wire.
Yeah, we're gonna have to lose the
So what
wire.
I'm gonna do is I'm gonna track this into the sheath.
PK, I would suggest don't pull the wire yet. Just double wire the catheter.
Okay.
Make sure you can cross it.
All right, give me a cyan wire, guys.
Good idea.
Any chance you can get a better
So-
lateral projection? Just move his legs a little bit, encourage his legs a little bit, or flip his legs down.
Mm-hmm.
So can I ask, what's the utility of keeping the sheath in at this point? Because we have to cross it regardless. You know what I mean? Is it just like keeping the vein open, or what's
Yeah.
the?
Yeah, sometimes you can inject contrast from the bottom. To
Or
see
you give me
where
a command, Dame, for now.
sometimes you see some contrast behind the sheath. But you're right. I mean, if you lose it, then either way, you've got to
And
wind
find
up
the scion, Dame.
with the sheath, with the wire across the sheath. You know, so
That's also why you're working to get into the PVIs.
Yeah,
Before you do, you could be bleeding if the sheath comes
yeah.
out, right?
So I think it would be nice to try to wire past the sheath first. If you're able to do that, that's fine. But if not, maybe pull the sheath back and then try to wire past the hole in the sheath. Sometimes I put the sheath on the surface of the vessel, not into the vessel. That helps to cap the hole.
Oh yeah.
So the wire doesn't exit through the puncture point and that the wire goes distally. And sometimes you use a loop, and a loop sometimes will get you past and make sure you don't wire into the hole. You know what I mean?
Yeah,
Yeah,
You
absolutely.
want to get the active wire to go into that sheath. And then it
No,
go back.
no,
Like
you
you
have to
said,
go
on the side.
beyond that sheet and go all the way down.
Oh, okay.
But I'm sure PK will work some magic. PK,
Or can you just leave a wire in so the sheet is not occluding the?
yes, that'll be the next step. You can
Let's
wire
mag
past
up, bro.
the sheet. If not, then pull the sheet
yep, I
and
did.
wire past it.
Hit the high mag. So you can see the sheet there. My wire is going to come out now.
Which wire are you using, PK?
Right now, just a command. They're looking for the scion.
I was wondering, because you got to sneak past alongside that sheath. You want something lubricated, right?
Yeah, you can see it's hitting that sheath right there. See?
Pull
It's,
back a little bit more.
I think it's too small. See, there it goes. There you go.
Is that in the sheet?
That's in the sheet. Is it? Yeah,
Yeah.
that's in the sheet.
Quick wire.
Maybe pull the sheet, but keep the wire or something there. I don't know.
What about putting a dilator in the sheath? Less likely to go into
Why
it.
don't you walk the
Why
sheet?
don't you just puff out the sheath as you withdraw, because maybe the perforator is higher up than you think. So you don't lose access.
It's probably not going to bleed that much because we're
Yep.
occlusive.
No flow coming from.
Yeah, PK
Yeah.
actually a loop. Sometimes a loop helps. Just see how it goes.
Well, the sheet's still there, right?
I pulled the sheet back.
Oh, sheet's back.
Yeah, you're hitting a valve or something. Because we didn't dilate this area. I can also puff from below. Oh, there.
Yeah.
You contrast?
It's not a sheath.
Can I get the dilator for the
vein is
sheath?
so small, you're probably gonna have to pull the sheath.
I think so.
Pull the sheet.
You want to pull it out?
You know what? Why don't you pull the sheet and put this in 018 wire right here?
Yeah. 014.
So maybe you can put the micropuncture sheet in.
Okay.
Yeah, pull the sheet and put a micropuncture.
The wire is kind of
PK, could you use your
heavy
finger and
scissors.
tell us where the puncture point, the distal puncture point is? You could mark that on the skin for us so we can see.
Right, maybe you could put, that's the distal puncture point right here.
Got it. Got it.
Do you have a micropuncture sheet? With a micropuncture dilator?
No, sheet.
The whole thing, I think. Let's see here. Let's see how much
Just
it
walk the
bleeds.
sheet out, see what happens.
Yeah.
Uh-huh.
We got a new micropuncture.
Yeah, it doesn't even bleed. We pulled the sheath
Okay,
completely out. So
Can we get a new?
sheet's out. We still have the wire though.
Yeah.
Can I get a new micropuncture? Also the diameter.
So worth imaging, or is it gonna just stain the field and then you get stuck?
Probably best not to inject contrast unless you really have to, but sometimes.
Nice.
Yep, you've got it.
Oh.
PK. The
Yeah.
loop,
Yeah.
That looks a very promising loop.
So if you
once you
have a good
pass,
loop.
once you pass the puncture point, you can give some dye, but
I think we're past the
maybe
puncture
a good
point.
idea is to use a 2.6 French device.
Right at it.
If you can follow that.
It's not going, Steven.
So what if you don't have a good loop there?
Maybe
Hold
a
on.
smaller support catheter, PK.
Yeah, I'm going to have to go with a smaller support catheter. Give us an 018 Trailblazer, guys.
If you don't have a good loop.
Full micropuncture.
Well, there could be, you're not assured that the blood will go down this way. So I would concentrate on getting that loop.
You've got to get in.
I would concentrate. But if you don't have a good loop, I think your wire looks like it's in, so keep that wire as it is.
Yeah, you
And slowly get the support catheter down and try to wire past, so you got a good loop over there. It looks like it's going through.
Mm-hmm.
So there are times where if you put the cover stent, you can't get a wire across. Leave it there as long as it's not bleeding out. And the flow is good. Come back another day when it's spasms. Come back and wire it through and then do what you want to do the next time rather than connect.
Have you ever tried wiring from plant?
Now pull the through and through wire first.
Okay, pulling that.
actually most of my experience is with posterior circulation. Yes, I've
Pull.
punctured the DP.
You don't just get rid of it. I have the micro in there.
No, don't get rid of it yet. Just
Because
pull
when
it.
you
Let's see.
puncture the other side, when you inject contrast, the valves open. You
Okay,
can
this is
see
the through and through
wire.
wire. Let's put a clamp on this.
Okay.
018 Trailblazer.
Yeah.
Pretty fun, huh?
Yeah, it's sort of interesting. You don't want to crush your stent, but it'd be nice to put a tourniquet now so you could bulk up those veins. Maybe the valves will open up.
Okay, let's put it. Actually, but would the tourniquet crush the covered stent now?
That's what I'm saying. Yeah, maybe.
Self-expanding
I
though.
think it's a good idea, PK. Don't put the tourniquet up. I think just
I mean, you can put it up in the thigh. This way, at least the venous flow.
you could, yeah. But I think you're doing well. The wire looks like a loop.
Don't lose the wire, guys.
The arch already. So just get the Trailblazer down and your
Oh, there's the wire.
in vascular surgery, you never send for the next case until you close the skin, right? So I'm not sure if you guys. Never.
It's sacrilege.
Never open to the what, fat ladies thing. Is that what
Yeah,
you think?
yeah.
Yeah, we're what, sorry?
It's not over till the fat ladies
Ladies
sing.
thing.
I don't know.
I'm gonna pull the
no,
micro
no,
out
no.
just so you have
Oh.
a little more space.
You,
I mean, that looks good.
You're getting there.
Yep.
Get it down to that second toe.
Right where the wound is.
Let me take a little puff here. Let me take a little puff.
You could inject some contrast if you want to,
I'm going to.
but not. They're not DSA. Just let the contrast dwell, and you can see it as a roadmap. You know.
So from below, you have a micropuncture sheath still in.
Yeah.
This micropuncture sheet is maybe it's still in, but it's got
What's
a
this?
wire here. You getting any blood back, PK?
Yeah, plenty of blood coming back.
Yeah, it's just a
getting all
micro.
the air
We
out.
downsized to the micropuncture sheath from below.
Maybe a full lateral projection might be a bit more useful to see the whole thing come in. I can see his legs are quite stiff, right? So try that.
Okay, I'm going to give a little dye.
That looks good.
There's your perforator.
Yep, you can see that
Yeah.
So wait a minute, you inject him from where?
from the catheter here.
So the question is, should I go forward, Stephen, rather than take this one?
No, I think that looks good. Just get a floppy wire and get it down.
Oh, yeah.
Oh, that one's bleeding out.
All right, give me a cyan blue, guys.
That's just extra, but it shouldn't be that bad.
All right, you don't have a cyan? Cyan black? Give me a black. 190, no.
Take that-
So give me another command.
One to turf, not the distal one,
Follow the calcium. Usually there's calcium.
rather than the distal one, because I think that there's extra at the puncture site, but I think the true channel is below that, no? I think that,
Pretty promising here. So
Okay.
go with that for a while and have a look.
So you take this one with this.
I can't see. So, but if you can't see the roadmap at this point in time, you can stick the bottom of the foot with a micro puncture and use that. If you had difficulty crossing the arch, you could re-stick the bottom with a micro puncture and inject some
Should be at the
contrast.
cyan, it would go right
Let's see,
away.
PK, I'm sure you'll be able to wire down, you know, so it looks promising.
So I'm going back with a command as, of course, our crack team here at Cyanide, meaning our how can you say, equipment team didn't order the Cyan. So Cyan would have flown. It's a great wire, Jit, and I love it. Unfortunately, in this case, we're going to have to work with the command. Let's see whether command is also a good wire.
Use a fielder wire or one of the,
Yeah, fielder you could try. I mean,
Anything floppy, huh? Anything floppy, hydrophilic floppy.
why do you like the Cyan, PK? Just super floppy, super soft?
super soft, super floppy, just goes.
We use like,
It's so beautiful.
those retrogrades.
so that's.
think that's it.
The black.
Cyan black.
You're almost there, man.
It's not going, bro.
No, shit, that's right.
Are you trying to take that channel to the right or to the left?
Yeah, that's it. There
Oh,
you go.
nice.
Oh, that's going up the great saphenous vein. That's
I would
okay as
take
well,
that.
but this would be the backup plan. I think it'd be nice to get to that collateral to the right.
Well, would you
see
want
the
to?
one to the right?
Would you want to balloon it just to create that channel and then try to get into the PT after?
See, try to get to the PT, but if you can't, then this is the backup plan to bring it up the great sap.
It just does not. I'm gonna pull back my catheter.
Pull back on the thing a little bit. Yeah. I think it's that stub.
Yeah.
That's right where the tip of your wire
Yeah.
is. I think that's the stub, but so the support
Nice.
catheter, this support catheter can be a bit stiff, so if it doesn't work, then have the wire go back into the great saphenous vein and just run on that for a while and see what happens. Yeah, that's fine. Yeah,
And that's okay, you've been a little super.
yeah, for a moment, then you can put in the balloon and stents, and after that you can wire down once you get flow.
Yeah, let's leave it here for
think
now,
that's-
Stephen.
Yeah, it looks good.
For now, let's leave it here. Let's balloon it now. So I'm just, we still have our through and through wire. We're going to keep it for now. And then we're going to track a balloon down. What size balloon would you take now?
I would say start with a 3.5 and then move up to a 4, just for starters. Or
So give us a
maybe use
3.5
low-pressure 4.
3.5 long balloon, guys. So,
That's what I was asking before. See that branch coming off by the ankle? That needs to get covered, yes?
oh, I see what you're saying now.
Do you
Yeah.
need to?
I would probably leave it and let it run, let the circuit run, because you're not sure what the outflow is. Then come back later on if you need to. You can coil this off from the
Gotcha.
great saphenous vein.
As opposed to covering it. right?
Yeah, because
3.5 long.
Spot there, right?
Yeah.
Close to the ankle.
150.
So the anterior system, because you're compressing on those stents as you do this, and you
Not
walk,
worth the risk.
it's as compared to posterior where you're stretching those stents. So I'm not sure how the covered stent will
What a
work
pain in the ass. I hate this
Yeah.
wire. I'm telling you, that's
But
a
if that was
hard turn.
posterior,
Oh, yeah.
I couldn't make it go up and down. It's
Well,
actually up and then down.
Yeah, well, let's just get a circuit going and then we can try, you know, yeah. Because the wound is this way anyway, so it's, you know,
Should be
hopefully that
good.
arterializes that way.
I know in some of the cases we've
So
had.
if you went to PT and it was a branch like that coming
Do you
off
want to
the ankle,
stent down
you'd cover
to
it.
that branch that they're talking about though?
I think I would, wouldn't
Yeah,
you?
yeah.
So Ajit and I just talking about how so Al, to our everybody there, the wire is actually the takeoff of the vein is actually anterior, and I cannot make the wire go anterior. So what happened is it dipped posterior, and then went into the great saphenous vein is what I'm thinking, because it actually points up and then down. So I'm not able to make that turn. So what Jit is thinking that if we balloon this, and then let's see if it makes, see the posterior bend right there. You see that? So this is a posterior dip. So this is a 3.5 in the loop. I'm going to balloon this right now.
Do you want to go all the way a little higher? up?
You want to go all the way up, Stephen,
Just
or
to
what?
where you see the saphenous?
No, I think you don't have to go all the way up because that's
Like
a
right
normal
there?
vein.
Yeah, I would just do
pull it back-
this.
I would pull it back to a little bit more. Yeah, about that.
Yep, I agree.
Just,
Right here.
Just low pressure. And maybe PK, if you can have an AP foot to have a better appreciation of where the
off-road
wire
map.
is.
Yep,
Just to give you
absolutely.
an idea of the anatomy for the guys over here. And you can see this is actually the great saphenous vein. This is the medial marginal vein that's coming down. The tip of the balloon is in the medial marginal vein, and this continues in the medial part as a great saphenous vein. And this is the trifurcation here. This is the one that goes forward and comes back.
Is what you were talking about
Yeah,
before.
and probably
So-
a good idea
so
is
obviously he's having pain.
Try to wire it.
To the proper,
way back.
to the tarsals rather than the.
Should we pull the through and through now?
So I think we'll pull the through and through wire now, Stephen.
No, I think it's a good idea. PK.
Yep. So we're going to pull the through and through wire.
As
I gotta
explained
deflate
to
the balloon to do
it. The best would be to get the wire to go left instead of right? Because
Yeah.
the left goes into the deep plantar system rather than right. But just get the circuit running first, do some balloon, get it running first. And sometimes those veins will open up, and it could be all right.
Let's go up again.
Yeah.
So we're going to open up the circuit again. He's having a little bit of pain. Steady.
Slow and slow because you're pretty much doing a controlled rupture of those veins, which are usually quite small. So just a little bit low and slow and see what happens.
You risk damaging access to the tarsals by doing this right now, or
There is a risk, but should be
I'm at
fine.
4 right now.
should you first or before ballooning to see because maybe you have access to them, right?
Yeah,
So that's into the superficial vein.
that's into the superficial great saphenous vein. So
Can I get a 4 monochrome?
PK, I think if you let it run first and you still can't see where it turns into the arch.
Can I get a 4 monochrome?
With an ultrasound and a micropuncture and use that as a roadmap to cross.
Yeah, I agree with you. I'm gonna walk the balloon back down. I'm just gonna come back a little bit, and I'm gonna balloon up again because you can see the bend right there into the saphenous. Let me just let it come down and then pull back.
I'm gonna advance the wire a little.
Yep, of course.
Okay.
So
Okay.
you said that was a 3.5 balloon or?
3.5. Okay, let's go up here. Okay,
don't see a
breathe,
lot of
breathe,
valves
breathe,
or
breathe,
constriction points. Do you see
breathe.
them?
Yeah, there is a
Maybe around the-
there is a constriction point.
There is,
Get some lidocaine.
Oh, there is, yeah, sorry. Yeah, there is.
Okay, senor, lo
This lighter.
siento. What are you at, 4?
At 6.
6. Okay, that's good. Leave it up for a little bit.
Yeah, of course. I'm so sorry, Mike. Go ahead.
Look at that. They're still looking for monochrome. We also like to do like a little purse string at the, I don't know how you manage the venous site, but once it's arterialized, it can bleed a lot. So we put like a little purse string like we do for fistulograms around it, and that seems to kind of stop it.
All right, down. Let's just take a picture. I'm going to walk it back a bit. So we're going to walk it into the stent, and then I'm going to pull my sheet back and take a picture. Actually, we'll inject through the sheet. Let's see how it looks. Hold on. I'm not going to pull my sheet back yet because I want to get the alluvias down. Okay.
So Steve, at this point, say you can't get inside the deep plantar venous system.
Oh,
Leave
push
this, come back another day.
Come back another day.
We can just push with saline maybe and be able to see the foot.
You ready? Ready to inject or no?
Can you push it with saline too?
Just
No, just like after, flush it with saline so it goes forward because we're
ready?
occlusive.
Cross or bidirectional. They'll probably go up.
Challenging to get through those valves, even if you
Yeah, that
take
could be very
the
Push it with saline.
Nothing?
He's gonna push it with saline now. It needs one more push, I think.
No, nothing went through.
Try it one more time. When he does this push, I think he's just moving. Oh, he already pushed it. Push it one more time with saline. Yep, now. Alright, so that's what it is. Oh, it's small.
Small as hell.
Could you do an AP shot and a little further on the toes and see if that lateral branch is coming off or no?
Yeah, absolutely.
The draw.
Okay, could you show that last run again, the last?
Yeah, I'm just.
Could you show that last run again?
Yep.
It's that collateral that we had, that we mentioned in the past, isn't that stealing blood?
So you see a pad AT vein where
By the end.
just about half a centimeter above the circle on the left.
Yep.
That's a pad AT vein. It will probably bleed back to the heart unless you can get a good outflow, and you could have to coil it later on. But I think as a start in the AT, these veins are pretty small. I think you should just land the alluvia. There's no bleeding, so just land the alluvia.
Are you okay with this? Because that's still stealing, right?
Sure, but the primary purpose of it, of course, the question is, Jose had a question, should you coil off the small little branch on the right? But the primary purpose in phase 1 is to get the flow going down the covered stents. As long as you get flow going down the covered stents, you can sort of trim and prune or wire the distal later on. So the last thing you want is to have the whole stent graft going down.
No, absolutely. All right, get us an alluvia. Walk this out.
Like the AV fistula is operatively, right? We leave a branch, we still let it mature, and then you come back and prune them,
Yep.
right?
So, PK, what kind of length and stent are you thinking of? Or
I was thinking about an 80. I don't know what you think.
Yep. I think it should get a little bit more overlap into the covered stent. So I'm not familiar in terms of length up the front.
Let's get a 6080 alluvia, guys. Or maybe 120, Stephen. We can this way go across the ankle. Yeah. Yeah, there's 100. 60-100 alluvia, guys. ACT.
So how far out do
Is
you
it
want to extend, guys?
I think PK,
Give me some
where are you thinking
saline.
of landing the stent?
What's that?
Where are you thinking of landing the stent at the distality?
You know, that's the question. I was going to land it right before it makes the turn. You know?
Yeah.
That's what I was going to do. More. Give me a 20cc syringe filled, please.
When you say you're gonna, what you could do is you could push a catheter all the way to the tip over a 2E and inject through, so you could maybe see the bifurcation in the AP configuration to give you an idea after you land the stent, because you really don't want to cover that excess going into a deep plantar arch. But I think it's at least
One more. The other thing we could do is give me a coronary twin pass. So we have a coronary twin pass catheter with a side port that you can inject. You can inject. So that's what I'm going to do here. I'm going to take a twin pass. I'm just flushing the. I'm still. Remember, there's no flow in this AT because I'm occlusive up top with my sheath. So what I did was I just flushed out with saline to flush out the dye, so there's no chance of clot. Our last ACT is 350 something. So now I'm going to go with the twin pass, and I'm going to inject with the twin pass. So this way, maybe we can see something now that we've established flow. So you're going to see this twin pass is a novel catheter. I know the vascular surgeons may or may not use it. This is used in the coronaries when you get into a dissection plane, or you want to get into a side branch and you're not sure. So it's actually a pretty cool catheter. Yep. The coronary twin pass.
PK, the vascular surgeons usually get one pass only, so not like you guys.
Oh my God.
Who makes the PK? Was the company?
I don't know who makes twin pass. We'll find out. Anybody know? Anybody know who makes twin pass? Dame, who makes the twin pass?
Suzuki is the same thing.
Yep.
That's a similar one.
It's a
very cool. It sounds.
So you can see the catheter is going to go down. So we have the twin pass catheter. So I'm going to go down. It's got 2 lumens. It's a double lumen catheter. So therefore, one lumen is going to come, and then you can inject from the that. So it's actually a monorail system, and then we're going to be able to inject. We're going to be able to inject from the upper port. So I'm going to have a JIT mag up here, and then I'm going to show you. Give me some nitro, guys, so I can give some nitro as well. And
Nitro.
If you have to put in a full AP,
Yep.
a little bit more RAO that might help to see the triceptation as it's hard to see. Yeah.
Yep. So before I stand, there's my twin pass catheter, right? So now I'm going to take some contrast. It is nitro first. So nitro is going to go down first.
So this should be going.
So I'm going to give about 200. I'm not sure I'm going to give all the nitro.
Go down and around.
Down this way. This is
Through the web space, it was like the artery.
This is.
So 200 of nitro going in.
Forward, back. So for me, it's this superficial vein.
Okay, good.
Forward and back.
Now give me a 3 cc syringe, please.
Probably
Play saline.
It's a little further back and then down.
Saline.
So I'm just going to flush my nitro in with the 3 cc syringe, and now I'm going to need some.
What's the best projection for seeing that perforate? Is it lateral?
Contrast?
EP? I mean, what's the angle there? Shoot.
We usually go AP. Al, and I'm going to do an AP shot here with the twin pass distal. See, that's the twin pass distal. So now I don't see it there, so I'm going to pull back again. Only question.
PK, you see that knob there? If you look at the last one, I think I see it.
There's a nub right there that Bhaskar is saying. Yeah, I see it.
Okay, on the previous run, you can see it a little bit clearer, the previous run.
Yeah, Jit is going to move it.
You see
there it is.
Adjacent to that collateral that's heading back north.
Yep.
Pad DP. This is a pad DP. So I think it's somewhere around here, but that's, it's good to.
I was wondering that before. The valves more preferential for the tarsals than the other way, right? In other words,
it's just filled with contrast right now, so you can't see it because of the subtraction. But it's probably
that little stuff
around there. Yeah. As you can see, just always goes forward and then split back this way. Right.
So Chris, are you going to stick another wire through the?
Okay. Give me another command, guys.
You're gonna put the second wire through that?
Yeah. So I'm gonna go through the second wire through the distal port here, and try to wire into that other one. And this is kind of a cool catheter because you don't have to lose your access into your GSV there. So at least you have a flow. But right now we have to try to find it. I'm a little worried about this not staying open if we don't have better outflow. Whoops. Sorry.
So PK, I was asking Steve a question like, would you ever think of sticking the PT or the lateral plantar vein and putting a micropuncture wire as a marker?
That's a great idea, but that's what Alfio suggested earlier. I think it's a great idea. I mean, Ajit, what do you think? You want to try that? If we try this for a little bit and then try that?
I think if we're struggling this way, that's kind of the next step. To really find it.
How difficult is that
was it?
technically to get through the valves because you're going against the flow?
I
It could
mean,
be-
So you
yeah,
should
it's
rendezvous, because if you have a wire down the plantar aspect, that wire is gonna sail into can only sail into the DP vein.
Oh,
And then
okay.
you could snare it from the top or whatever and then rendezvous it, but I think PK, just a suggestion that if try a little, but if you can't, just let the circuit run first.
okay.
I think it will. I think once you put the Illuvia, I think it will run because there are a lot of collaterals. There's a paired AT vein, and
So-
that looks like it will keep the circuit running.
So Steve, is there any time you would actually do anything more like coil on the initial setting, or do you just let it run and mature and then bring it back?
Yeah, I think probably a good idea is to just let it run and think about.
That is a nice catheter, man. I like it.
Because if you stick the plantar, which is large, the wire will sail up the DP vein. So I'm pretty confident that once you let it run, you'll be able to connect the two together.
Yeah, I agree. It's what's that? This is the
Right.
command.
Command.
Because right now that wire in the great saphenous vein could be splinting the stuff, and maybe that's not allowing.
Taking out the orifice of it.
Yeah, maybe that's not allowing the thing to go into the deep plantar, but I'm sure that when you wire from the bottom the other way, it'll come up.
It has to loop the other way to
Yeah.
the left, right?
Yeah, it's gonna go down. Yeah.
Nope, it doesn't want to go, guys.
Okay, PK, I think you're doing well.
Nope.
Just
You want a curve on that, or?
I have a curve, yeah.
Can you,
Wire.
can you advance your wire and then use like a super cross?
that's into the looks like the tarsal vein going lateral.
Yeah.
Maybe just make sure it's not in the subcutaneous space because you do have a hole there somewhere. So that looks
Yeah.
a bit tricky there.
Yeah, you got a point. So just leave it then, Stephen. Put the super.
I think just leave it and put your Illuvia and let it run, and then stick the bottom of the foot and connect up the top and see what happens.
Okay. So I'm just gonna walk both. I'm gonna walk this out then.
So I would land the Illuvia. Maybe PK, what do you think? Maybe before that blob of contrast that you see, you do see a blob of contrast when it turns back. Maybe land it. Maybe once you put the Illuvia, the thing will be a little bit clearer. Maybe it may not be so clear on your screen, but it's pretty obvious on our screen, the staining of the contrast when it dives into the perforator. Probably about here. So this is the bend going down.
I mean, it should match the arterial system, which is that dive right there, right? That's where you first webs into space.
Illuvia, guys? Yep. So 60100 Illuvia going now.
So just be careful as you're coming across those tapered.
Oh yeah, we should look up. Look up.
It can be a bit tricky. Especially
Well,
past the bend.
Well, that's why we didn't lose, Ajit and I didn't lose the access because of that reason. We're a little concerned. Even now, I think we're both very concerned about this. We might have to switch out for an 03. It's not coming out, guys, the back end.
Not yet.
It's something.
I see.
Yeah.
Oh,
Close
Hey.
out.
Yeah, the yellow's got to come up here.
Yeah. Okay.
It's that
Okay.
pain in the ass.
All right, ready? So I see I'm a little worried about that stent.
Yep.
Yeah, and we still
Well,
have the
let's see.
014 wire.
Let's see, we'll go slow.
Let it open.
Yeah.
Nice and slow.
All right.
Oh, yeah.
Nice. All right, it worked. Oof. Now it's not tracking. That's all it's going.
That's probably the puncture point. You might have to balloon that a little bit because you don't want to rip the vein. Yeah.
Yeah, so might have to balloon it.
Try one more time. Let me just straighten it out for
You
you.
have a micropuncture catheter there, right?
No,
No,
she's
no,
not really-
not going. All right, let's get a walk this out. We're gonna get a balloon now.
Or you want to try an 035 wire?
Yeah,
or-
we're gonna try an 035 wire. It's a good idea. Give us a Navicross, 035 Navicross.
Well, yeah, you're right. Stent was already down.
We can balloon it first and then 035 if not.
Give us a 40 balloon, 40 long balloon now. 40018.
Collaterals, you talk about bringing them back. When is optimal for you? Are you letting it kind of like mature like you would for
I would.
like
I mean,
about a week, 3 weeks, 4 weeks?
You want to advance the wire a little?
primary reason
Oh,
is
yeah,
to get the
100%.
circuit running. Right. So I think if you have the chance.
Oh,
to
120.
back and you need to try to connect the
I think
dots
if this
to
looks
get
good,
the wire running, I think
we
that's
should just
better.
pull the sheet back, take some pictures, and then
Let's see how it looks. Call it a day, and then we'll go to the next one.
Close that, just whatever you want to close it with. There's no puncture at the same time. Right.
Oops. Oh. So we're gonna go with a 4.0 balloon and then switch out for an 0.35 wire. So we're gonna gently expand it, as Steven said, with the 4.0, and then we'll decide. So get an 0.35 a super core and a 0.35 this one Navicross or something. Okay. So this is gonna be painful again, as you guys know. So let's see. So he's rock solid. You know, great nursing as always. Our pressures are solid. The groin looks good here. So we're just going through. He's sleeping like a baby, but he will wake up with his balloon. Okay.
yeah, I think
that's good. Yep. Just. Yeah, we're not going to go this far with the alluvia anyway. Let's do it here. Yep. Okay. That's the spot that didn't expand.
Right there.
That's 6.
Is that a 4? Yeah, I heard you correctly, Pete?
Yep, it's a 4 OL.
Is that a semi-compliant or non-compliant?
It's a non-compliant.
A little tight at that ankle, huh?
Yeah, I'm gonna pull it back down. I'm gonna pull it back, and we're gonna go up tight here.
You think just stenosis up there?
Gee, you need to cut down on the release those bands.
Oh yeah.
Go up
no,
here.
we'll hawk it. We'll hawk it.
We'll hawk it. Yeah, it's overhawk.
Yeah, I know. That's I think STRYKER has to put that in the package too.
We just.
So PK, when you're presenting this to your administration and your team,
Don't do that.
what do you recommend? You know, because
It's 14.
So we're at
present this.
We're at 14 atmospheres with a 4.0. Okay.
Not really opening up.
It's not really opening. So the worry now, Steven, I'm sorry, Buster, I did hear you. Yeah. The worry now, Steven, is we put the alluvia in, it's not going to open.
Well, or we rupture it and place a covered stent farther down. That's what we might have to do.
The option is to rupture and put a Viaband over there.
Oh, you want to go higher?
You want to go back in?
Yeah, I'll just go up higher and see if we rupture it.
Yeah, maybe what you want to do is, maybe you want to exchange that for a 35 wire or I don't know.
Yeah, that's what I'm going to do now. I'm going to exchange it for a 35 wire and then try once more with the alluvia.
Before you go up real,
that's
looking quite.
Okay.
Because that's really small, just where it's going to shut down if we don't break it.
Yeah, I think down.
Where it's going to rupture.
It's not expanding there.
Yeah, because these veins are very small. If you do a bypass, these are really small veins, and they're not arterialized, they're fresh veins, so they could very well rupture.
But
So
I think
you don't want to go higher than a 4.0.
I think for a start, no.
I mean, just the way it's doggone.
That ruptured. That's not a good sign. Okay, I'm gonna walk back here. Go up here.
Get stiff a wire in now.
So here you just do a Viaband if it.
Yeah, I think that would be wise.
All right,
10.
let's get a Viaband ready, guys.
Maybe a 10 Viaband, something like that, in case.
Yeah, get a 5.5 10 Viaband.
5 by 10 or something.
5 by 10 Viaband.
It's 12 still. If we're gonna cover stent it, I could just rupture it now.
I just go slow.
Okay. Foot's still soft and everything.
You want to bring the balloon down and go for it, or?
Yeah, I'm gonna pull forward here, down.
Okay.
I'm gonna come back here, and then we're gonna go for it. I'm gonna go for the gusto here.
You want to shoot a picture? You want to shoot a picture first? Maybe you got lucky. Maybe it's not.
Go
so
here?
Bad.
Yeah. I agree. I actually, that's very reasonable, Al. We're just gonna balloon here, and then we'll shoot a picture. This is the spot right here. It's really bad.
Yeah. That's 12, 14. $16.
20.
See why you meant the AT is not so easy.
AT's not easy.
It's like the similar spot to that PT where there's always that one valve, one tight area.
I don't know on the anterior system where the valves are. I'm not familiar with that, but this could also be the fact that you're dilating the veins, and it could be that bunching up the veins, just like when you bunch up the sleeve, like that.
Okay, okay, down.
So this could be, yeah.
All right, we'll take a picture.
So that is also non-compliant.
That's not compliant.
Yeah, non-compliant at 20 atmospheres there. So we're gonna walk it out and take a picture.
I'll leave it.
So don't judge us if there's a lot of bleeding.
No, don't worry about it.
We got a covered stent ready. Ready,
You wanna
guys?
take it here?
Yeah, I think you have to come out.
Okay.
Would you use a Dorado and a?
Next step, let's see, like Alfio said, if I got lucky, I got lucky. Let's see. All right, ready? Ready, David? Inject.
We're probably gonna have to flush it too. Do we have that Vibe-on ready?
Injecting.
Inject. Okay, didn't rupture.
No,
Oops.
Yeah. that's right. Just
I
we'll have
think
to.
you're gonna put the Vibe-on in because you've got a returning collateral through the AT.
But
Yep.
you got your foot back, that's the lateral tarsal down there, right?
Yeah,
That's
the loop
puncture
looks
point
good.
there.
Yeah, it's a puncture point.
There's
Yep.
a puncture point leading out there. So
Yeah. So, all right, so you want to go ahead and put the vibe on in, or you put the Luvia in?
I think the Vibe-on, my friend. Sorry.
Yeah.
Yeah. Okay, vibe on, guys.
Your circuit is open, that's nice.
And how far are you gonna take the Vibe on?
100.
To take it to
Oh, wait.
You want to use a?
50-100? Perfect.
this spot.
Okay, you take it where you would have taken the Olivia.
Yeah, I think so.
So just playing devil's advocate though, Stephen, you got a nice outflow from it. It's probably not high pressure. Do you need the Vibe-on?
That's what I'm thinking. I mean, and plus we're injecting directly into the AT. That's my question. Why not just put an Luvia here? Vibe on.
I can see a limited rupture where all that contrast is staining, and I think it's probably safer to put a Vibe-on in because you're not sure, because you do have a rupture. You're not sure what's that's going to form. Is it going to have a whopping big pseudoaneurysm as the guy walks further on in?
Well-
You've also got a returning AT vein that's bleeding back the system, and you got an ankle and uncertain area. I can't tell you about the AT and the DP what's going to happen, but in the posterior
Show me a bubble jet.
it's pretty safe.
But what's it? You really think it makes that much of a difference, Alluvia, between Alluvia versus Vibe-on in this area?
You got a bit of bleeding on top, PK. Some
No,
contrast coming from the top. See that?
Yeah, you're right. Yeah, there's.
Why is that?
I don't know. He's quite tense too.
Yeah.
Interesting.
Let's get this Vibe-on and we'll take a picture.
Let's get the vibe on down. We'll take a
in and
picture.
Shoot some color from the top and see what happens.
It's not going. There it goes.
Nice.
No, that's all it goes. Unfortunately, no.
Might need a V18.
Nope, not going. Let's try.
You want to push a little harder? I'll give you a little more back tension.
Nope.
Nope. Okay.
I think you're across though, Pika. Last image, where was it? Just with some Bowman landmarks, see where that perf was? Because I think you passed it.
Yeah, we're past it.
It's just that
Right? 'Cause
narrow
it's above-
area.
The perf is right there above the ankle. Or at
Close.
the ankle, should I say.
Go right at the flip side.
I think if we put a V18 down.
Do you want to switch out for a V18? Give us a V18, guys.
Because I don't know if we're fully past it.
Let's see what's going on up top. We can give a little dye. It's
Yeah.
a little. He's very tense here. Give a little dye up top.
Let me just walk out the Vibe-on.
Yeah, you don't have to. You can inject through the 7 French,
Yeah,
right?
okay.
You're fine. We can inject through the sheath.
All right.
Let me see. Give a little dye here. Inject.
Okay.
Oh, the sheath is back. That's why. Inject now. Are we ruptured in the pop? No. No rupture.
Okay.
No rupture.
Maybe put the V18 and put the sheath into the AT to kill off the bleeding.
Yeah, there's some bleeding there.
Did
Actually,
we
good.
post-dilate those stents?
Yeah, we did. Okay.
Is it outside that 035 on that last run?
Can we do a
Is that tiny
DSA?
squiggle?
Let's do a DSA. Ready? Oh, yeah.
Huh.
What is that?
You're going around the stem.
We got to post-dilate those stents, I think.
And we got to post out those stents. All right, let's change that for the V18.
Okay. Let's do that first, probably.
Let's change the V18, guys. You want to post dilate the stents first?
Yeah, let's post-dilate.
Yeah, we're gonna post dilate the stents first.
Yeah.
So what do you think happened here, Stephen?
Get it fresh.
Well, you don't have outflow, probably, and you're doing a control rupture, so.
I don't know though, but we had nothing. This is new. I'm surprised. Give us a 6.0 balloon, guys.
So if it's not leaking from the top, if the top stents are sealed well.
I mean, that should all be fixable, yeah. I mean, you have a lot of overlap. Okay, if you balloon those, you should be fine.
Yeah, I'm surprised, Al. That's what I'm really surprised at this.
I think we had a ton of overlap.
Some infolding, you don't know, right? But you're at least 3 centimeters into the artery, and the whole vein is relined all the way down. So.
Yep, 6.0 balloon, guys.
Bleeding is like actually through and through it.
So where are we?
I'll play it for you guys. It's bleeding in the stent.
Yeah.
It's bleeding within the stent.
Yeah.
Unusual, but have a look just in post deal that.
Yeah, he's definitely tense. So we're gonna have to make a fasciotomy here. So let's get the let's seal this first.
You never know there's a fabric tear or something, so if your balloon doesn't work, just immediately put down another covered stent in there.
Yeah, it could be a fabric tear, but I had no problem, Al. Like I told you, we deployed it nice.
Yeah, it looks straightforward. You never know, man. Manufacturing, you never know.
That really doesn't look like a leak around the stents, though. That's pretty impressive. That's strange.
So you're gonna reline it, balloon it and reline.
Did the stent move or anything like that?
No.
Yeah, you had a lot of
All right, let's go up here.
Right here.
So we're gonna go up here, and then we're gonna take a shot whether it stops or not with the balloon up. Go up. Or maybe the native vessel broke, but we're across it.
Yeah, unless that overlap.
That initial shot, you can't see that little one second of the initial shot is really short on the inside.
Okay, that's 12.
12.
Okay, good.
Okay, down.
You want to take a picture, or?
Yeah, take a picture now.
This will exclude a proximal site problem there.
No, it's leaking from the.
It's from within the stent.
It's the material. It's the material.
It's a material tear.
So
Actually, just take down a balloon, shoot again, because if it's still bleeding, it's not an infolding issue. You have a hole somewhere. But that's rare. It would be double hole, right? Double two layers. What's the likelihood of that?
Do you think it's not well opposed proximally? That's why
Could
it's
be.
bleeding?
Let's take another picture here with the balloon there.
Okay.
Let the balloon come down.
Balloon's deflated.
All right.
Inject.
Yep, down. Go up to the balloon.
Through the stent.
Yeah. Go up.
So you gotta reline that, so you might as well take the 5.
All right. So we have the we're just gonna put the
They have
balloon
a
up.
200 stent. You want to just use that?
Yeah, we'll just put another 200 vibe on. Down. Yeah.
I'm keeping the balloon up.
Yep. Let's get a 200 vibe on. 6.0. Oh, 5.0. We have a 5.0 200.
5,200. Yeah.
You have a 5.0 200, Dame?
Isn't that a 3.6, Steve?
We don't have a 5.0 20. 250 is too big.
It's like.
How about a 10? You've got a 10 that's open up.
15, even a 15 should cover that.
15 would do that.
Yeah, give us a 150.
You can see where it is.
What's that?
Got a 5x10 open up. You want to cover that? That might work.
Yeah.
Yeah, we can put a 5x10,
Well,
but I'm
that's a
going to put a
little-
150.
Let's
Give me a
do 6
150.
because it's a 5.5.
Let's give a 6 150.
Inflate the balloon while you wait for the stuff, guys.
Yeah, no, balloon's up, Al. Balloon's up. Balloon's up. Yep, there we go.
So it's after the tipper stent.
Yeah.
What size balloon is that? What size
So
balloon?
I think this is a fabric failure, don't you think?
Because I think it's right there.
That's a fabric failure.
You can see that bleb right
I've
there.
never seen it before, but looks like a fabric failure, so just cover it up, and I don't know why.
Yep, 5 150.
6
150.
150. That's good.
Fine.
That's good.
So we're going to go with the 6 150 and balloon it again. We're going to work fast here. Then we'll go distal. So that's interesting. That I wonder how the fabric failed. That's interesting.
So that's the BD stent, right?
Okay, we're ready.
Is that the 50?
It's a
Ready?
5.5.
I'm gonna deflate the balloon.
Watch the distal wire.
Yep.
5.5.
5.5 150.
The stent 5.5.
Mm-hmm.
You said 5.5 or 5.0? 5.5.
What's our ACT, guys?
It's cooking.
Okay, give me the 150. There seems to be now stasis in the stent now. Hmm. All right, let's go.
Yep, got wire.
Mm-hmm. No, it's gone.
It's first stop.
Right there. Let's go. Deploy.
PK, just come back just half a centimeter, I think, just to overlap the overlap zones between the two stents. Yeah.
Okay.
Oh, down.
Deploy.
Yeah, down a little bit. Oh, okay, that's fine. Yeah.
Okay.
Deploy.
Deployed.
Yeah.
Just in case the overlaps.
And then do we have a 6 balloon to post dilate?
Yeah, we can use the same stick. Is that okay?
Let's just get a fresh one ready.
Get a fresh 6 balloon. Take a picture. You want to take a picture?
Let's take a picture. Picture?
A lot better. Okay.
Yeah.
All right, go ahead.
That's all old.
Fabric is it?
Don't know when.
Mm-hmm.
So the stent distal to the conical stent was initially a 5.5.
5.5.
5.5.
And now they put
right?
in a 5.0.
Very tight.
Yeah, that's fine because the stent
Right.
barely goes
I'll
beyond
probably have to do a
5.
small one here
It's
then.
more tissue, so 5 would be 5 is fine.
Because if it was here, I'd have probably put in a 6.0 stent, but that would probably fold it.
Exactly.
All right, give me the 6.0 balloon.
Oh, I've had a VBX fabric tear. When I
Do we
was
have that
in the
V18?
VBX
Can we open it?
fabric tear.
V18 300?
Went to the ward and make it. And actually
Gotta switch out and then
Mm-hmm.
do the distal and then hopefully
And
that's
then we'll
it.
be done. Okay. So we decided, Jit and I decided we're going to do a little mini fasciotomy here once the case is done.
I think that's required, yeah.
Make sure you guys don't lose the distal wire, guys. Oh, good. The wire's there. Okay,
Where's
good.
it?
Let me see above it, Jit.
Okay.
Where's the distal balloon? Okay, let's
That's
go up
the
right
distal
there.
mark.
Let's go
Do
up.
you see the end of the Vibon?
The end of the Vibon? You mean balloon? That's the end
Oh,
of the
both?
balloon.
Okay.
We're good. We're good there, Jit.
Okay.
Yeah,
Go-
you're beyond the end. You're beyond the end.
Yep, go up.
Just low pressure should be fine. Yeah?
Yep. Alright, we can, it's deflated. It should be.
Go up here.
Not too high. You don't want to rupture just in case. You get
Yeah,
a
just-
tear.
We're just
Just going to 4.
We're just going to 4.
Yeah.
Okay, good.
Good.
Down.
Then we gotta do proximal.
All right, let's get the prox here.
Yeah, you're just ironing out info,
Yeah, right
that's
there.
all, right?
Yep.
That 5.5 stent
down.
is, it comes to the kit.
Comes
Down. Okay, let's walk it out now.
Can we get a 035 catheter?
We'll walk this
Or
out.
018 catheter?
018.
Yeah, let's get 018. Switch out for the V18.
How's the foot? Is the foot swelling up too now?
Here you go.
Foot's okay.
Okay, show me down. Show me down now.
You wanna just make sure we're sealed up here again?
Yep, we're gonna do a DSA. Ready?
1 sec.
You're out. Okay, DSA.
Look at that.
Let's go to another view.
Yeah.
Actually, this is. That's better. Oh, I can't really see here, but we'll see. Ready?
Uh-huh. Sorry, I went off
No,
flow.
no, wrong one.
Oh, yeah.
It's the manifold. Ready?
Nope.
I gotcha.
Can you come up here? I don't know which one's
Here,
coming.
here's a 018. right, go for it.
Mm-hmm.
Push it with saline.
Okay.
Slowly
Outflow
push it with saline.
Outflow issue now. Okay, let's go. No perf. Give us the 035 catheter. Go AP.
Want 035 or 018?
Oh,
Do we have? Okay.
Oh, 018's fine.
018's right here.
Perfect.
Running good.
Yeah, it can't be bleeding if it's not going anywhere.
Mm-hmm.
Yep.
So we're going to change out the distal to an 018 wire and then try the Viabond again distally.
Do we have a V18? Let's see here.
Guys, can we get a V18 wire?
You got it?
I got one.
Thank you.
Maybe PK balloon it one last time before you send the Viabond in. You could repeat
Yeah,
it.
we're going to balloon it with another balloon. What size you want? Give me a short 4.0 coronary balloon, guys. 4.0 high pressure room 4 is okay?
Yeah, they just did the diagnostic up and over. I told them to either just ask something.
018.
So go do that. Go do that. Yeah. Just get that over with so we keep that room moving.
Do you have an introducer? Okay. 403? Great.
Get us a 4.0 balloon here, guys. A 4.0 coronary. Oh, no, we can't do coronary because it's a 018 wire. So give me a 018 4.0 balloon. Short.
You got wire?
Not yet. Yep, I got wire.
Okay.
All right, let's go. Just when you thought you were done, huh? Let's go. 018 4.0 keeps it exciting. So, Steven, have you had this type of fabric failure before?
Thank you.
Hmm.
Lucky us.
Lucky us, right? All right, let's see this one.
We can post these stents up to 6, and usually I've never seen a fabric puncture, but bleeding depends if you have good outflow, and then you really, even if you have a micro tear, that fistula is going to run south, that blood's going to run south. So maybe it's a combination outflow,
Well, the outflow is definitely an issue here. You can see, so we need to get this outflow. There's no rupture here, like Al was saying.
I'm gonna
Am I
advance.
past it?
I don't think so, but I'm just gonna advance wire.
Where's the
wire? Hold on, wire.
Yeah, maybe it doesn't extrapolate, but I tell you, in the dialysis world, we're rupturing veins all the time and they leak, but if they're depressurized because of the shunt, they don't bleed much.
Show me
You just kinda
the balloon.
tamponades on the outside.
I can't see the balloon now.
You're up there.
Oh, there I am. No, is that the balloon?
Yeah.
There it is. All right, let's go up here.
It looks like the loop is spasmed, right? Because you can see the contrast up until then. Might need to give some nitro.
Okay.
Oh. Yeah. Looking for our nitro.
It's hard to see anything.
What are you at, Jim?
12.
Okay.
Just can't tell if it's open or not.
Can I get a new? Oh, here we go.
Well, looks open.
Yep.
Down. I'm gonna pull back a little
Is that
here.
another 3.5 balloon or 4.0 or what is it?
4.0 balloon.
018 40. Yeah.
It's 100
Okay,
cc's.
that's 14.
14.
It's opening, right?
It looks open. Yep.
Yeah.
Okay, down.
Should be enough to track a vibe on.
This is tracking, so you can walk it out. Give us the Viabond.
Where's this device?
What's my blood pressure? Okay. I'm
You're
gonna give
also
it.
the patient.
What is that?
You're also the patient. I'm sure your blood pressure is high right now, PK.
This is the Vibe.
400 of nitro.
Yep, perfect.
He's in the zone.
So if it's not bleeding there, why not an alluvia?
I think there's a rupture in the vein. Probably better, safer.
As it pressurizes and builds up
Yeah, you never know because these are small little veins.
Yeah, and there's a little hematoma on the dorsal foot, so I think it's probably safer to do covered.
Ready?
Yep.
You go.
Mm-hmm. Real?
Yep.
Show me above, guys.
Want to straighten out that ankle? That might help you track the viaband a little bit more. Point the toes south.
Yep.
Maybe that might help to track the viaband a little bit. Yep.
Which one that was?
Ah, my God. Not going.
I think we're far enough there.
Maybe. What do you think, Steven? A little more, right?
Yeah, the other option right now, you don't have bleeding. The other option is to bring the wire, puncture the bottom, bring the wire up, and then get the outflow. And you don't have bleeding right now, right?
Mm-hmm.
So you could puncture the lateral plantar, and then rendezvous the wire and bring the viaband all the way around, and you'll be able to do that. The true and true wire. That might be something.
Let's see if I can give you a little
Use
more
your thumb on the
rail.
external skin and help squeeze it through.
Because there's possibility if there's a rupture there, you're actually.
I think you got further, actually.
Yeah.
I think you went a little further.
I think we went a little further. I think I'm going to deploy here, buddy.
I think you need a little bit further. Yeah.
Why don't you exchange for 035 Supercore and put a 035 viaband? You're gonna have.
The thing about it
You need an
is,
eight-French
the vein is quite small and the viaband is rough on the outside, so you could be ripping through the vein as you're pushing the vein through. So I'm not sure.
I think we're good
And
here.
you don't have a free rupture right now because you just have balloons. So maybe the other option, if you have a little bit of energy, is to stick the bottom, bring the 014 wire across the arch, rendezvous with the catheter in the covered stents, and then get it through and through, and then do a bit of ballooning first to get the outflow going, and then you've got a stable situation right now, and in the DP it's not ruptured, So
Well,
it's a bit more work.
But the only thing is, it looks like I'm far enough, though, no, Steven, or no?
I think Steve's worried that you may have telescoped the vein forward.
Yeah, because the veins are pretty small over there. So I don't know if you can land it and see what happens, and if it doesn't work, then puncture the bottom. Yeah.
Yeah, that's what I'm going to do.
Yep.
All right.
All right.
Can we get a fresh 4 balloon to post dilate? 4100 018. 4100 018.
Mm-hmm.
So the stent on the bottom end is not opening. Just be careful as you're pulling back. Oh, yeah.
Yep, I see it. Mag up.
Yeah. Yep. Okay, 1 second.
Yeah, it's opened up already. Maybe you'll put your finger in and maybe.
Yeah. 4100. Yep.
Yeah.
Thank you.
It's not coming back.
Now push it forward a little bit. Maybe that might free up the.
Thank you.
Careful.
There, it goes forward now.
Mm-hmm.
Hmm.
Want me to try?
Yeah. Let's see. Nope, it's pulling back. Let's go forward again.
You want a buddy wire down there and then put a micro balloon and balloon it open.
Yeah. Give us a buddy wire, guys.
Second V18.
Give us an 014 buddy wire.
I'll do that. Let's try one more time. I just massaged it.
Oh, yeah. The lift is big. It's got a bit.
There you go. Nice, Ajit. Beautiful. Don't worry. Give us a 4-0 balloon now.
Yep.
It's quite a constriction there. Is that right?
Yeah.
Stuck on something else, huh?
No, it's actually caught here. Caught in the neck.
Where?
Down below. It's caught down below. Let's go forward again.
Right on the stenosis, yeah.
Yeah, let's go forward again. Okay, now try. There you
There
go.
we go.
Good. All right. Give us another 01840 balloon. Yeah, that's why we do them live, right? Jesus Louise. All right. Let's
Go on.
do it again.
Yep. 4100.
So we're going with a 4-0 now. There you go, brother. I'm
Toss.
gonna balloon.
Okay. Are you allowed to have a beer in the hospital at this point?
No beer.
You can get you one of those hats that you have the beer on the side.
I love it. Rail guys?
Not so.
No wire yet.
Oh.
It's any consolation, you're doing a great job, PK.
Oh, why?
Yeah, we're pulling it back because we don't have wire in the back, unfortunately.
Oh,
Okay, now I got wire.
Something up top.
How long is that wire, 300 or what?
It's,
It is. Huh. Okay, got a rail.
let's see. There you go.
Sheath came back. Sheath
Yeah,
came back a little, is it?
a little bit, yeah, because I'm pushing the vibe on so hard.
Yeah.
V18s are brutal.
There you go.
nominal 6,
Now you can crack the shit out of it.
rupture 16.
Oh
That's the
my.
medical term.
No, but PK, honestly, for us, not done this before, watching
Not
this.
too high pressure because you don't want to rupture it distal to the.
Yep.
Mhm. These are all very small veins.
We just want to open it. So that's good right
Let's
there.
open up
Yeah.
really.
Yep, that's
Okay.
good. Down. I'll just go forward a little bit.
Yeah, there's that little waist proximal that
Yep.
we could be a little more aggressive.
Right here. This we got to open, Stephen.
Yeah, go for it, yeah.
Are you gonna open that distal lip? Yeah.
I'm worried.
Go, Jit.
20,
That's 20.
40.
40? Okay. I only see 26 on this.
There you
Nice
go.
opening.
It's opening.
Nice, open.
That looks pretty
It's
good.
good enough for a moment, yeah.
And it didn't recoil, thank God.
Okay.
Let me just go to that distal lip a little. You're up? Or you're still,
I'm down now.
it's still not down completely, huh? Can you rail it now for me?
Uh-huh.
Go up slightly. I'm still not out of the rail. Yeah, go up slightly.
That's 4.
6.
6.
That's good right there.
Okay.
Okay. All right, let's walk it out. Now let's see.
I think we're going to have to balloon the pedal loop. It looks spasmed.
I'm going to give more nitro.
Yep.
More nitro, guys.
Did you use I just had one.
I got the sheet.
There's a syringe right here. Where did it go? Oh. Can I get some more?
You're still gonna have to punch the lateral contact, right?
If they have the energy, I would suggest,
More.
but,
If there was work, right, it's the Outflow 4, yeah.
No, we're definitely we'll do what's necessary. I mean, the
got
whole
one?
idea is to do it right. If we have to get the lateral plantar, we'll get it.
Okay.
I think it's a good time to pull back the sheath only after this run, right? After this run, might be good to pull back the sheath and let it run a little bit. See what
Yep. That's what I'm going to do. I'm going to give a little bit of nitro now. 200 of nitro. Here we
Go
go.
flush.
Great.
I mean, it's good to see all that.
More nitro when you get a chance.
Well, it's good to see
not
all
getting
the
bigger, right?
Can't
The
tell.
anterior system is pretty difficult. Small veins, if you cut down on it, I mean, Alf would know these
All
are
right, let's see.
very, actually, things are very small. Maybe you had a glimpse of what the vein was.
You pulled the sheet
You
back?
saw the parallel
Yeah.
vein. The parallel vein can be pretty small.
Nope. That's all saline. That's all saline. Let's start from up top. Ready?
1 sec. Okay.
Outflow.
Yeah,
No
just
extra.
hang on down, man. We keep this stacking confidence, so you can see if there's an issue anywhere.
Come down.
Maybe a good time is to put a 4 French catheter just within the covered stent distally and do a run there.
Yep.
That will help see the.
Oh, there's flow. Slow.
Has to be the outflow, that's, yeah.
Yeah. You
All
want
right.
to put a
Like, give us
catheter?
a 4 French catheter, guys.
There's a Navi on the back table.
Give us a Navi.
Yeah, I think we needed the V18 to track, but it probably spasmed.
The Navi cross.
Yeah, I'll be.
We got it. Ready. So So we're going to go down and puff it out and see what's going on distal, and then we'll get posterior tibial vein access now.
Haji, how's that calf feeling? Is still reasonable?
It's just stiff.
All right.
I mean, we'll open that up. Yep, ready, brother. So there's outflow issues, you can see.
Yep.
Clearly outflow issues.
We do have night
As
power
long
back
as it's
table
not
too.
outflow at the stent, if it's outflow west of it, it's manageable. That thing's tracking nicely.
Oh, wow.
And now I'm just gonna puff out. I'm gonna give nitro, guys.
More nitro right here for you. You want nitride?
Yeah, both, I guess.
Okay.
Okay, what about an 01? What about an 014 wire right now? You could let the veins relax a little bit. You think?
Oh yeah, 100%.
Right. Because the V18 is a real brutal. Could be causing all of them to spaz or.
It's a dangerous wire.
So you're gonna go back with your Grand Slam?
Right now we're giving some nitro, and then we're gonna take a picture, see what the foot looks like. But Steven, you always recommend taking a picture without the wire, right? Once you're close to the end, so it doesn't keep open any
No,
valves.
I actually I was hoping you didn't pull the wire. Just use a TUI and.
No blood.
No blood.
Yeah, but
It's gotta be spasm
because
just
you're not
distal
sure
to the
if it's,
stent then.
There's a hole right now. And,
Sheath is back, right? It's in the pop.
yeah, probably inject in the stent graft. Maybe since you got the wire out already. So.
Well, we lost, the access.
Yeah.
I think it's right next to the stent, probably.
Flush.
Are you going to inject through the catheter? Or is that
Yeah, I'm just giving nitro.
Okay.
Yeah. You don't want to put a wire in there, because if you drop back a centimeter, you may lose an axis if there's a ledge there.
Yeah, I know. I'm just gonna take a little die here, Al. Let's see. We'll take a little picture here with a DSA. I mean, let's see. At least we know what the hell we're dealing with.
Okay.
Nice.
Okay, now the problem is that little ledge. You see that?
Yep. If you're not bleeding now, you want to alluvia that. Maybe you can alluvia that.
The problem is, I want to show you one more thing. Show us a little distal legit for me. So I want to show you the toes where the issue is a little lower. A little more. Yeah, there you go. Right there. Let's take a shot right there. Yep, let's take a shot right there. Okay, that's the bleeding there on this access site.
That's the access site.
Well, PK, now that you've got a catheter, maybe the wire will go south. You see that stump there?
Yeah, I see it.
You see that stump pointing down? Maybe that might be a good to just use that roadmap and just go down. Maybe you'll save yourself a distal access. It might.
All right.
Might go.
So give us a fielder wire. Give me a roadmap, brother.
Do you want to just fix that distal edge first,
That's a good point. Should we just fix the distal edge first?
so we don't get caught on stuff? Let's go proximal to distal at this point.
Maybe go for the wiring first.
Anyway, right?
Just get a wire. See if you get lucky. You get a wire across.
Fielder, thank you.
I think it's the one on the right, PK.
You're
Right itself, yeah.
You're talking about after the branch that comes off.
The one that's pointing. The only thing that's pointing south on the right side. I think that's the one. But
well,
you might need a soft CXI to, because I thought the quick cross was a bit stiff. Maybe a CXI or something like that. It's you could telescope that into the 035 Navi. Or a smaller Navi into a bigger Navi, something like that. Let's see how the wire goes. If you're lucky right now, the wire just sail right through and you don't have to puncture the bottom and just connect the dots and just.
Stephen, we just discussed it. If you did puncture the bottom, for example, where in the foot would you do it for this situation?
I think just under the foot. It's probably going to need a support catheter to direct.
Prakash, can you use a supercross catheter to direct it down?
I'll try, brother.
So the 120 is gonna look down.
There you go.
Yes.
Is that it, Stephen? I can't tell.
Bring the support catheter down and then.
Hold on, let me
maybe
just
go on a
see.
lateral foot.
I gotta go lateral. Exactly, that's what I have to do.
Go
Yeah,
lateral.
Promising. No, keep on
That's-
AP. You're good there.
No, the other.
Keep on AP.
Keep it on the AP.
Yeah,
No,
bring
that-
the
no, that
support
looks
catheter
good.
down.
No, that looks good. Now it's gonna make.
That looks good. Yeah.
Now
Bring
it's gonna make the
support
loop.
catheter
Yeah.
down very gently.
Let's see.
Rough turn, huh?
Do you want to take a micro?
No, don't wire PK, just double wire if you need to, but and bring it past the bend first. I think bring it past the bend and.
I know, but the problem here, I'm not going to be able to get past this bend. Hold on, let me try. Let me try to go cranial.
Sometimes you have to spin the catheter a little bit just to.
Why don't you use like a fine cross or something that is.
Huh?
What's up? What's this?
Step it in. That catheter is gonna pull everything out.
0.1,000.
As long as he just takes this bend, I think you'll.
Yeah, one more.
Yeah, it's gonna be a catheter like a Corsair or.
All right. So I think we're gonna have to go with this catheter is not gonna go. What's our ACT? Yep.
014 support catheter.
Use a fine cross or Corsair or Turnpike.
No, I think keep the wire and use a smaller catheter. That's
Okay.
a good idea.
Give us a smaller catheter, guys.
Don't lose that.
014.
014.
Turnpike and see if it
Give us an
comes
015 teleport.
Teleport.
Walk this back. Yeah, this is not an easy bend here. Look at this bend.
And then cross it in the AP configuration. And
Okay, I got it. At least now, the nice part is we know he's not bleeding anywhere. Looks like he's got outflow. We're just going to have to get this outflow well, and then he'll be fine.
Oh yeah, tougher
PK,
one.
The first case, which was an AT that we did, took 4.5 hours, PK.
Well, you know, we were we were cruising along, guys, and then of course everything went bad. You know, we were cruising along.
Yeah,
But hey, you know, that's why we do it. That's why you know, we appreciate STRYKER believing in us and putting this together. Let's see how this goes. So, Stephen, explain this to the audience. For me, the bend and the tip of the wire has got to make another U-turn there, right? That's the whole the challenge. So that's I
can't quite see the bend because the foot is not. I'm not sure which angle it is right now, but go back to AP and see if you can wire past the valves, and you can always puff contrast if you want to.
I'm afraid to lose the wire here, though. You see where I am?
Just go back on AP foot, a bit more REO. Yeah.
Okay.
Okay. Go back and see if you can send a wire, and it should go. And a little bit of contrast. Once you're past the bend, you're okay to take contrast.
So you want me to advance the catheter here, right?
A little bit, yeah. Okay, and then pull the catheter back just a touch, and then try to poke past. You should be able to get past.
Yeah, but you want me to pull the wire out now?
Yeah, I think so.
Oh,
So
you're brave, man.
the
catheter is looped on it.
itself, so maybe
Yeah, the tip of your catheter is just a little bent.
I think the whole thing is just looping it.
Where's the teleport? I can see it.
There you go.
Oh, yeah.
There you go.
There you go.
Oh, there you go.
I think it was probably against the valve. Oh, yeah, you got it.
Looks great.
All right.
And, have a look and make sure
Let's
that
go to the
it looks
lateral.
good.
I think it's in the SSV, Steve.
Yeah, let's have a look.
No, we're good.
That's
Oh,
perfect.
I see, all right.
We're
Full
good.
lateral, if you could. Full lateral, take a picture and.
Yep. Yeah, we're
Oh,
okay.
you got it.
We're
Oh,
okay.
you're good.
Okay, good. Nice job.
So, you want to
Nice work.
change that out for an 018 wire? I would suggest a command 18 that is not so stiff.
We don't have a command. This is an 01 catheter by 014. I'm going to take a command super stiff command. Give me a command extra stiff, guys.
But that's an 014, right? So in case you have to eluvidate, it'll be hard to get the 014. It's better to get an 018 wire across.
You guys have road runners, they're not as stiff as the 18s, but they're not bad.
What are they called now? Road runners? Do we have road runners, guys?
Road runner.
That's an
Old wire.
oldie but a goodie.
Yeah, that's an old wire.
That's a Cornish wire, right?
It's a very old one.
All right,
Nice.
let's try this. We'll keep with our what we do.
Yep.
Right?
We know a lot about you, man.
Give it to myself, that's sorry, I'm aging myself.
All right. So what balloon do you want now?
I think a 4-0 just to encourage the across the band and then save maybe an alluvia. Let's see. You know,
We get us a 4-0 long balloon, guys. A 4-0 120 balloon. Oh, 014.
Across the arch, you're gonna place
yeah,
the.
there's low pressure across the arch. It's very low pressure across the arch, and then
There you go.
pull that
Strong
balloon
work.
back,
Yeah, nice work, man.
and the balloon that portion
Never give up
again
on each other.
before you
I love it.
Consider what happens and let it run. Pull back the sheath and let it run and see what happens.
So
Well,
the
You got
microcatheter is a
Yes, sir.
teleport you use?
Yeah, it was a teleport I used, Jose. So Jose, that anterior posterior bend was the problem. So luckily, after Ajit and I stented it, Ajit told me just to
We need
give a
that-
little
we need
puff,
that
and I think
stent.
that's the right
Balloon.
thing. And can I have a 4-0 balloon, guys?
I think Damien's looking.
Dame, any 4-0, 014 balloon or 018? 018 is fine, Dame. Whatever you got.
Prakash, is that teleport similar to a turnpike or a fine cross or Sarah?
Yeah, it's
You have
the same
014
thing.
now.
It's the same thing.
I'll take a.
It's what we use. It's what we use
60.
a lot. Actually, Ajit, let's go with the 018 because we can change out the wire.
Okay.
Let's go with an 018, and
Flow
we'll put an 018 command in, and then we can track the alluvia, which I hope will go. I'm still worried about that distal issue past the Viabond.
Ledge.
Yeah, I'm still worried about that. Should we shockwave that, guys?
No, it's a vein.
4120 018.
I know. Why not?
You might just break some bones.
Thank you.
You might just break a bone.
Yeah, that's what the market
Thank you.
said, right?
All right. Worst comes to worst, Ajit is ready to open the directional
Oh my
atherectomy.
goodness.
He's like, let's open the
So this is.
alluvia goes all the way down to where?
to the bend.
Just before it turns down. Yeah.
Nominal 6.
Ready?
No wire yet. Got
All
wire.
right. So hopefully this balloon tracks. Let's see.
Is this by any way contributing to the U.S. economy?
Yeah, 100%. So that little bend was a pain in the you know what. So let's see. I think that's enough.
Fun. Nice.
Nice.
That's enough.
Just low pressure, my friend.
Low
Low
pressure.
pressure.
Not no pressure, but low pressure.
No, you know there's a valve right there, right? That's the issue.
Thank you.
Let's go up.
So the valve is where?
I think where the catheter was buckling earlier on.
The honest truth is I don't know because we don't run down the 80.
You want to go back to AP?
Yep, we'll go back to AP. Ajit's going to go back to AP here.
That's 4.
Watch yourself, Michael.
Oh, sorry, bro.
You see that bend right there, guys? That's the loop right there. And so Stephen, I would land the alluvia in that spot, no?
Yeah, I think where the skin shadow, well, just before it turns, right?
Yes.
Maybe, you know, the
We
darker
at
skin
4?
shadow.
At 4.
Well, you bring it down and we'll communicate, but I think you have to bring the pressure of the balloon further back to get that ledge.
What size is
Down?
the balloon?
That is a 4.
So
Do you want
let's-
to switch out for
Yeah,
no
I'm going to push
A1?
this up now. Hold on. Let it come down.
Still deflating.
Yep. It's not going. Okay.
I think it's okay, PK. Pull it back. And
Yeah, pull it out. Yeah. Pull it back. You got to go
Pull
up
it
here.
back.
Yeah, go up here.
Go for it. Yeah.
Yep. Go up here.
Yeah. Go
Go up here.
A little bit more distal. Send the balloon a little bit more distal.
Yeah, push the wire up at you.
Yeah, watch the wire.
Yeah,
That's
let's,
Okay.
let me go a little distal.
Hold on, let me deflate it.
That's a touch.
Right there.
Okay.
Yeah.
Go up.
Yeah. Can you do a
That's,
single
4.
shot to see if the balloon effaces? Maybe that might be useful.
A single shot. Oh, I'm sorry, you were saying?
Do a
Corner?
CD to see if the balloon
Corner.
is opened up.
Keep it in corner.
It's not. It's not opened up.
Yeah, dry CD.
You want to bring it back and go be aggressive then?
There's a little waste there, the vibe on it.
Yeah.
Gotcha.
Yeah.
Oh, sorry, that's a DS.
Can
Okay.
you do a dry CD?
Yep.
Non-DSA?
Yeah, it's not opening there.
Yeah, we're gonna pull back and go up high. Pull it back now.
Yep. Oh, you got it. Like
Right there. Let's go up.
Go.
Wait, doesn't watermelon? There we go. That's 10, 12.
It's not connecting, yeah.
It's coming. It's coming.
Get us. You want to do a serenader?
I'm afraid you ruptured the vein, my friend.
What about a Wolverine
So-
then?
Yeah, just keep going at the balloon. It's a 4, so it's a very small size. Keep going up at the pressure. What are you at?
We're at 18.
18.
He'll come. He'll come. What is this, Highlander?
No, this is just a 018. We can get a 40 Highlander. Do we have a 40 Highlander, guys?
It's 20.
Do they still make Dorado balloons?
Yeah, they do.
It's coming. It's coming. It's open up. Is it open up?
I don't think so.
Yeah.
You
You want to do a corner for a sec?
Oh, sorry.
Sorry.
My bad. No, it's still not open yet. Go to 22. Keep going.
Do you want a 4 Dorado?
How about a Jade?
You can try a Jade. I don't think I have 40 Jades though.
Maybe deflate the balloon and put the balloon a little bit more south.
Down.
Is this a non-compliant? This
It,
is a
it sounds silly, man. Why don't you use a short balloon, like just a 2 cm coronary, because that gets dissipated through that length. You don't have that pressure getting transmitted to it.
I agree. Go up here. Go to 22 atmospheres. $24, $26, $30. Wow.
That's opening, that's for sure.
That's where the ledge was, right?
Yep.
Yeah.
You understand why that didn't go through now, man? I think it's like quite the ledge there.
Yeah.
Yeah, we gotta try on a different balloon, I think.
All right. Get us another. What are the balloons we have down?
I think PK, maybe it's time to use a cutting.
All right. Get us. We got to change out for an 014 wire. Then we don't have an 018 cutter. Actually, so we have to
do we
change out
ever
for an
change
014.
out?
There's an 018. So we got to change out for an
That's
014.
Dorado.
Oh, there's 014, right?
We never switched it out,
Yeah,
right?
this
So
is
whatever
an 014. So get us an 014 cutting balloon then.
balloon.
That's why we don't go down to 8. Always pretty tricky for me.
I know, I think this is the first time I've seen an AT case live.
Oh, yeah.
Myself, yeah.
Audio work, you know.
This is a rare opportunity.
So the majority of the times is PT.
Rupture.
99.9.
So our first one is not gonna be AT.
You got where?
Mm-hmm. Yeah, go ahead. Pull it out. I want to take a picture. Careful. Mhm. Good. Take it out. I got the wire.
Okay. Yep.
Out. Okay, I don't have the wire. Thank you. Oh, it's DSA, but it's not DSA.
Nope, nope.
Okay.
There's flow. It's still snow.
Okay, give me DSA, guys.
Yep, gotcha.
Can't leave that.
What do you got?
DSA?
Yep. Perfect.
This may sound crazy, but it's never mind.
Much better.
Wow.
If it's still got bleeding at the puncture point, or is that?
6.
No, that's just a fistula. No, it's fine. I'm going to cut this here, Stephen, and then we're going to have to put the alluvia.
Yep.
Your prep is like normal.
So, yep. So just gonna, so we're gonna put the cutter in that spot. Make this a roadmap, guys. Get me a
What size cutter
4-0.
are you using 4?
4-0, and we're gonna be a 4-0 high pressure coronary balloon, 4030. So at least we've got outflow now, Al.
I was gonna say, at least now you have some outflow. The pressure it won't be high, even if there's some extravasation. You shoot tamponade with that kind of outflow.
And of course, the sheet is still in, right? PK?
No, I pulled the, Ajit and I pulled the sheet back.
And see emerge.
Oh, I see, okay.
Okay.
So-
You want a roadmap on this? Oh.
Oh yeah, can we get a roadmap?
Ah.
No, never mind.
That's a pretty stoic patient you have.
Yep,
So,
right there.
so rationale for doing AT in
There.
this case was what? You wanted to preserve,
The
preserve
PT.
line? Yeah.
Okay, so here's the cutting below the 4-0 cutter now.
It's slow.
Slow.
Yeah, pop.
I think this got it.
We
Yeah,
got
it worked.
It worked.
Yeah, it's open.
Yeah, looks good.
Okay, down. I'm gonna just pull back a little bit.
Yeah, let's go.
Go up again.
So bleeding.
Hopefully there's no bleeding. That's what I'm thinking. you know, everybody's saying.
There and then do a run and see what happens.
Oh no.
Okay.
Fucking thing is stuck.
That's stuff.
Show me. Fuck.
In the sheath there.
I think it's in the stent. Show me above. Oh no, it gets more exciting.
No, you're in the. It's just
Oh,
the
in the
sheath.
sheet, thank God. I thought I got caught in the stent. It's not coming back.
Hold on.
There you go.
Okay.
Oof.
All right.
All
Enough
right.
drama for one
Enough
case.
drama, man. Enough.
Watch the wire
foot
here.
shot.
Watch the wire here.
Take another
Hey,
flick.
I was trying to take a cutting balloon out of a slender sheath the other day, just slice the slender sheath, the whole length of the balloon, the whole length of the sheath.
Are you serious?
Oh wow.
Ready?
Yeah,
DSA?
they cut.
Yeah, they cut. All right, let's see.
There's the blades also.
That's quick.
Oh wow.
Very nice.
Okay,
Looks good.
Yeah.
it's very nice.
So PK, since you've got a 7 French sheath in, get the Illuvia into the stent, into the straight stents first before you do a roadmap.
Okay.
Because you want to land the Illuvia right at the turn in a full AP configuration.
That's very nice, guys.
Yeah.
Okay, so let me do this here. So let me get the Illuvia. Get us the Illuvia, guys. Here's the AP, full AP.
What do you want? A 6? A 5?
You want a 6 or I think we have a 6, right? 6 Illuvia.
6, yeah.
How long?
Yeah, so you have to follow the Illuvia as it passes all the stents. So have a look at the Illuvia as it's coming down. Just
Yep.
make sure you
Mm-hmm. So
How long?
6.
Oh, we have it. Good.
6
We have a
100.
we have a
Once it's down,
Shorter.
once it's down,
Yeah,
you can
we'll
do
try
a
it.
DSA because it's a 7 and Illuvia is a 6.
So we're gonna go with a 6-0 Illuvia, guys, on an 0-4 wire. So wish us luck.
Flush that again.
Yeah, I think it'll go.
You're so positive, Stephen.
It's too hard.
You're so positive.
You got wire?
I'm not joking. I mean, Ajit and I already. You don't understand the looks we're giving each other. We're like, really? Well, are we really doing this here? Show me above, bro. Let's watch it
Yeah.
above.
You're doing a great job, actually, if you want to know.
Oh, thank you, man. And just telling you, it's just not been fun for both of us. Wow, that's tight, guys. Whoa. Oh, no, a little bit of,
Yeah.
no.
Hmm.
There you go. Okay.
One sec.
Okay, follow.
One sec. Okay.
Moment of truth.
Nice.
There you go.
Not
That's
going.
probably-
That's it.
I think that's probably far enough
Okay,
there,
at
no?
this point of time, maybe a 35 wire might be worthwhile.
So you want to change it? You want to get rid of this? I can't wire this with 35. I got to exchange it.
But don't you think we're
Yeah,
far
exchange
enough?
it out.
You want
No,
to do a
we
picture?
gotta go this way.
Terumo.
You want?
PK, maybe a stiff or a soft Terumo to help it slide a little bit better.
All right.
And
So
then cross, change
yeah,
it
so we
to
got to walk
Terumo,
this
because
out.
the
So
Super can be quite stiff.
yeah, we're gonna walk this out, and then we're gonna get the 035 Navi cross and a soft glide, guys.
You get straight Navi. Straight. I think we have an angle. You don't have a straight. Okay.
No, angle Navi cross is fine.
Okay.
And give me a soft Terumo.
You got wire?
Do you have
Yep.
a stiff Terumo, PK?
I do.
Stiff.
Oh, get us a stiff Terumo, guys.
Long one.
Give me the Navi cross.
Navi cross right here.
No, we got to go further into that bend, right, Steven? We weren't quite there.
Yeah, correct.
We got to go further, yeah.
Oh, you don't want to just.
No, we
I
got to go
see.
all the way down into that bend.
You're almost there.
We'll do it.
You're making history, PK. It's a tough case.
Yeah, well, listen, this is the way to do it, right? We got to do the right things.
This was supposed to be the easy case.
Yeah, this is the easy case, by the way, guys. The next one you'll see.
You drop the alluvia too.
You know, it sounds, just a question, guys, it sounds silly. If it doesn't track as a O35 platform, they have the V8, the what's it called? Cook makes the 518s. They're an 018 platform, self-expanding.
Nope, not going.
They're not drug coded
Spin
though.
on the Navi cross a little bit. Spin on
Here,
the
I'll
Navi
try
cross.
spinning in.
I'm spinning it, bro.
Yeah.
No, it's not going.
In that case, change for an 018 and see what happens. Yeah.
All right, 018 wire, guys. Let's walk this. Give me an 018 Trailblazer. And give us an 018. Give me a V18 018. Actually, do we have 018 Command 18? Give me that.
You know, they're microcat, they're 018 microcats. This way you don't lose that bend. You can get your microcat all the way up to the ankle and then switch to an 018.
What do you mean? You're talking about 018, the Cook Microcat?
Yeah, just like most of the microcats, you know, except 018s. Like a Renegade or one of these other things. This way you don't lose your wire across that bend again.
No, what I'm going to put an 018 catheter all the way down and change out for an 018 wire and then try the Supera again. Only question, Stephen, should we balloon distal a little more aggressively?
I think it's just an 035 thing. So I think once you change out for 018, give it a go. And if it doesn't, then reballoon it with a 5.
But what about using a Supera? That's not a bad idea.
A Supera may not be a bad idea.
Using a Supera, because they'll be 018. May track better.
Not going, boys. 018 catheter, not going. Wow.
Huh.
Balloon?
Yep, get us an 014 40 balloon. 40 40 30 014 balloon, Damon, another one.
You got one?
Yep.
There's that there.
Strange.
50, PK?
Yeah, Dame, get us a 50 balloon.
NC?
50 NC coronary, Dame. 50 NC core.
Oh, yes.
No bleeding, right?
Yeah.
Also no.
Right before the SE.
Not yet.
Not yet.
We have a lot of hematoma going on. What's going on up here? You think any issues?
I don't know, I'll take a look once we're done. I'll do it at the end.
You okay there?
Huh?
You're going to have to do a little fasciotomy?
You know, just make a
Right
small
there.
cut and just let it drain. Nothing crazy.
I'll be right back.
Tough.
That's strange though, because the 018 balloon tracked.
I know the 018 balloon track, but this one won't track.
You want a fresh one? I'm sure we have a used one.
Well, they're getting a fresh 50 coronary balloon.
Okay.
We'll put that down there, and then we'll try.
So how are you deciding how far you want to take your alluvia?
So, Stephen, a good question from a Jit. How are you deciding where you're going to take the alluvia? Looking at this configuration, what you have of the still film, you see that the loop of the wire. My concept is to take it to the beginning of the loop. Is that right or wrong?
Take it down to Chinatown.
Yep, 5015. Chinatown.
Is that over the wire?
014. Monorail.
Monorail.
I think you need to have the projection in AT later on once you dilate all that stuff with the 5. Just go slow and slow, but bring it up to 5 since you don't have a choice. You have to get the outflow going. So the veins are very big, so I think it's okay.
Yep, that's what we're
Just,
going to...
bring it up slowly. Almost there, guys. Just nice and slow.
It's not an easy one, but let's see. Here we go. So let's. So far, Lisa, we're stable. Only question I was talking to Jit is about the timing of the fasciotomy. Should we just do it now, or
I think it's well, you're not really pressing on anything. No essential artery, so I think there's nothing there that would harm the patient right now. So it's not like there's a native circulation that's being compressed by the hematoma because all that circulation is coming from the back anyway. I
right?
think it's okay to wait till later, as Ajit says.
No balloon here or across.
I think just across.
Okay, let's start here. Let's start here.
Short balloon, right?
All the way back, right?
Yeah, it's a 50 short balloon. It's a coronary balloon, so we don't have longer 50s. Generally, we have shorter 50s to post-dilate these stents. So, unfortunately, we only have a shorter 5. Thank you, Jit. We only have a shorter 50. We're going to go up slow here. Nominal is, Dame?
Nominal's good, yeah.
Yeah, that's 4.
What is it, Dame? 18 is nominal?
What?
Oh, and 10 is nominal. Yep.
So
Goes.
that's 4, but he's feeling it. So
Yep. That's 4. He's feeling it. We're going to go a little further in. Hold on. Go up there. Just go to slowly 4, 5.
okay.
Feeling it a
4.
lot, Stephen.
Yeah, that's enough. That's
Right there.
Right there.
Down. Actually, that you could have gone up to nominal, huh?
Yeah, that one was good.
That one was good. Let me go here. Try here again.
so this part is not really essential because this is the outflow. The flow will go towards the foot. So maybe just the area
here.
there about that. And
Would you all?
Go AP, guys.
that in, I'm going to put that in RAO position a little bit so you can see what's going on.
RAO. Yep, more.
Alright.
Yeah, oh, sorry. This way towards us. Yep. No, I think that's.
That might be it.
No, it's just hitting
Hitting
something.
something. Oh, let's do this.
Raise the table. Go RAO. Keep going. More RAO. Good.
Yep.
Thank you. Thank you. Down.
So do you always
here?
recommend ballooning this, or are you worried about barotrauma
I
ever?
don't normally balloon it, but I think you have to get the outflow going and you have to deliver that.
That's the valve, Stephen, right
There it
there.
is.
See that? That's the valve.
Usually no valve there, but I'm not sure why you're getting a stenosis over there, but
I'm telling
doesn't
you.
matter. You want to bring the alluvia. You want to move the balloon back a little bit.
Yep, down. So, go up.
Yep.
Yeah, this is where it was getting caught.
Yep. That's open up.
There we go.
Good.
Okay, down. I know there's a
You have to
valve
take
there.
the nose cone of the alluvia around the bend. So where your back marker is previously, or where your front marker is right now, is probably where you want to land the metal part of the alluvia. Maybe between the two balloons, a little bit between the two markers, So just before it takes the bend, yeah.
Okay. Breathe out.
Watermelon.
Down. Let me go forward a little bit. Sorry, my friend. Right there.
PK, after the procedure, it might not be a bad idea to get someone to do a nerve block for him to take the pain away because he's going to be a bit sore from the hematoma and everything. And yeah, keep going on that balloon.
It's 14.
18.
$18.
18 atmospheres.
It's coming.
It's coming.
What's the burst on this balloon?
Burst is 18.
All right, take it to 20, I think.
20.
Yep. It's 20.
Is that a
22.
valve or what's that there?
22.
No, there's normally no valves over there, but it's probably the junction between the superficial and the deep veins, and you might have to cut it since you have a 14 wire. You might have to cut it. Do a run and see what happens. Yeah.
Well, yeah, I will. I'm just gonna. We're just giving it a little moment here.
Yep.
It kind of worked in the,
Yeah. Pull the balloon back into the covered stand. You'll still be able to do a run. So and you can bring the balloon down again if you really need to. See what it looks like.
What are you at?
24.
26. Amazing. 28. That's it, max. Okay, down. All right, we're going to do a run here. Bring it back into the covered stent. We're going to balloon this area as we go forward. Okay, go up here. Down. Get the cutting balloon ready again, guys.
So we need a new cutting balloon.
Down.
All right.
All right, we're going to do a run now. 1 second. Ready? Yep, I
might have
got to
to
do this here. All right.
Again, a new
Those
cutting
good,
balloon.
cut it and put the Illuvia in and hold free.
There you go.
So when does that go?
I think cut it, put a navy cross across, take the Terumo wire, and then put the Illuvia in.
Yeah, we got it. We got to cut that.
Yeah.
All right, let's cut it.
Low pressure. Sorry, what was that?
You know, that thing goes, no.
This is a pen. That's a pen. This is a short set. This is the.
Michael, let's own this.
Oh, sure, something.
That's a short saphenous. That's the original short saphenous. Go around and feel and it's gonna.
And those two is a paired PT.
That's a paired PT vein, so you can see the paired PT vein by nature is a lot more robust.
What is this?
I think you got to cast him so he doesn't rupture this. So this way he'll heal.
You can bring that down
You
here.
know?
Yeah.
All this is gonna put itself. A little bit
Yeah,
later on.
yeah, for sure.
Back from this patient deserves an angio
Go ahead,
a little bit
buddy.
later on.
Mhm.
Hopefully all this will come
You-
up.
Bro, you build this whole thing, okay?
No, don't worry
No, I'm
about
serious.
Just push the back forward.
mean, I'm-
Or because the wood is.
I'm already
so
done with my
close
reviews
to
for the year.
6 weeks. Give it a
it.
little-
Already?
When you do what?
You bring them back and do what?
Yeah, you could see if you need to coil. If you still don't see stuff.
I
going
checked it the other
forward,
day. Done.
Nice.
Literally going to take off. Problem is, SS will go crazy. Okay, right there. It's too funny. All right, going up. All right, Dr. Coombe, this is like the 10th cutting balloon we're doing. Oh, got it.
It's amazing how quickly. that
Dude, cutting
works.
balloon is the way to go.
You want to go in and out a little bit, just make sure you got it.
Yeah, no, we're just gonna, yeah, we're gonna go different views here. Okay, down. I'm gonna go to one more, pull back and go up here. Let's go up here.
Mm-hmm.
10, 12. Yeah, I just go to 12.
It was like 14.
Yeah, I think we got it.
You want to do
Yeah, I think we got it. Okay.
picture?
DSA? Ready? Oh, yeah. Sorry.
I think I figured it out.
Yeah, so this is, this is the thing is, so this is the die. And then that's the pressure. This is the pressure, and that's the saline.
Wolverine cutting balloon, is it?
So fancy.
Yeah.
Hey, Prakash, are those Wolverine or
Oh,
what?
shot.
Beautiful.
That looks good.
Okay, PK, I think don't send the Illuvia down just yet. Just change out for 35. I'm sure your Navi Cross will go across.
Yeah, we're going to do the Navi Cross now. Give me the Navi Cross, guys.
Where'd it go?
It looks pretty good. You do need a move here.
I would, because this whole area was scarce severely. So, I mean, unless you're prepared to bring the patient back for an angio, maybe in 2 weeks' time, this thing,
2 weeks time.
this is gonna scar severely. And that's the outflow, because once you have this secured, I think you're pretty decent. You know. I would probably land at Illuvia all the way here. Maybe.
We have a 035 wire? Super coarse.
No, we need the glide, he said.
No glide wire.
Get the glide wire, guys.
Stiff glide. 260 stiff glide wire. Got wire.
1,000, please. Yes, sir.
I'm actually thinking that you want to take the Illuvia across the arch a little bit.
I agree. I don't think it'll track though, Steven. Honestly, I don't think it'll track. Let's see how this behaves, and we'll decide. Yeah, it's not tracking.
Stiff angled.
Nope.
Twist
Yeah,
it. Twist it.
I'm twisting it. Oh my God. Okay.
You gotta twist it.
Yeah, I know. That's what Ajit and I were twisting.
Lots of twisting.
We're twisting together. The glide wire.
This is 035, right? Oh, right.
So,
yeah.
you know, I got to tell you,
Yeah.
I'm really blessed here, man, to work with him and have vascular surgery with us. It's amazing to, you know, it's like we bring different talents to the table, and it's a lot of fun, you know, the equipment and these kind of things. And of course, having a JIT next to me makes me fearless because I rupture what I want. You know, even though Peter always tells us we're crazy, you know. It just actually, I did the sheet's coming back. I'm going to hold it.
Yeah.
So, you know, it's
So fearless.
It just be fearless because you have a JIT here. So it was
Well,
fun.
I'm glad I make you feel that way, I guess. I don't have wire here.
Nope, you just keep pulling.
I'm just going to
slowly,
keep pulling slowly.
Good, it's
Okay.
out.
All right, Illuvia.
Illuvia. All right, moment of truth, Dr. Coombe.
Do you want to flush that?
Yeah,
Yeah.
make sure you flush the Illuvia because there's some blood in the Illuvia sometimes. So.
Yep, that's why we were doing it.
So PK, I would suggest you fluoro the eluvia going down. And then
Oh, of course.
Once the eluvia is in the Viabahn, you can do a shot because it's still.
No, the distal Viabahn is where I'm going to do the shot. And then I'll try to advance it. There's going to be a lot of bias,
No
Stephen.
worries.
I got to be honest with you. I'm not very confident here. There's going to be a lot of bias on this wire because taking the catheter out was very stiff. Show me above, brother. The catheter was very stiff, so we'll see.
What wire are you using now?
This is a stiff
ACT?
glide.
Stiff glide, yeah.
ACT 275.
Okay, let's take a roadmap here, Ajit. Oh, I can do it. Sorry, brother.
Okay.
All right.
You guys are too fancy here.
I know, we're all fancy. All right. I think we're obstructed with the alluvia. Oh, no, there it comes.
It's coming.
Okay.
All right, just go on body landmarks and go for it. You can play the last run and have a look, but
No, I'll re-inject and I'll just wait longer. Okay, we can see it now. I just have to go distal. Rail, brother?
Uh-huh.
Yeah, this is the problem.
I think it might have spasmed a little bit too.
keep going. It's coming.
The sheet's coming back though. No more.
I think that's.
You don't want to use a super core or a
So
stiffer
you know
wire?
what? Pull the wire a little bit. Let's see if we
Okay.
could pull the wire and push.
The super core will bend. You
Pulling wire?
stop and it'll bunch.
Oh, okay.
PK, I
No,
think
no,
deploy
no.
over here and come back another day if you have restenosis.
Yeah, I think so.
That's fine.
All right, we'll deploy.
Watch the nose cone coming back after you deploy.
Where are they feeling it so much?
So it still has-
Watch the nose cone coming back, PK.
Hold on
Yeah.
one sec. I'm not sure. I think we're good.
yeah.
Okay.
So
What's the wire?
Why?
Yep. Mm-hmm.
Normally you want to have a stent.
Normally no. But in this case, because everything is there.
That's fine. Leave it there.
But
It's
normally
really
you
stuck.
you like to leave it where?
I know.
Normally I come from the back.
Stuck like crazy.
The alluvia.
Stuck on what?
Oh,
Cross.
Oh, wow.
Across the arch.
Okay.
No, not across the arm.
That's if you're coming from PT.
I'm out of wire here.
And just pull.
I've suggested to go across because this looks very.
You're out.
confusing.
Okay.
You can take it.
It's okay.
Good.
Worst case,
In
maybe
DSM.
you can check out for 1.8 balloon
Yeah.
now or something like that. You'll try.
Mm-hmm.
I don't know.
But if you were a PT, you said you would have stopped there?
Yes.
Then you wouldn't have gone
No.
on.
That's not. Same spot, huh? Just shy.
What about a DCB?
I'm thinking a DCB, so change out for 1.8, or you know what, your policy, okay, you can put a Navicross there, try to send a Navicross across, if it doesn't, then double wire the Navicross with a 14 wire and DCB that corner.
Yeah. So just give me the Navicross and an 018 and an 018 Boston Ranger DCB for 40, a 50, 5020, 5040.
Just a question, it's not a flexion point there because it's going between the tarsal heads. Could you put a coronary stent in there?
I've done it in the artery, I haven't done it in the vein, but the sizing could be a problem. The coronary will go up to 5.0, a Megatron would go to 5.0, 6, yeah.
Those 6,
So maybe, but I'm not sure.
I mean, it's not flexible, granted, but
Yeah.
it's kind of hard to walk away and leave that there like that.
Yeah, I think a balloon will go across it if you can change out for whatever balloon.
No wire
go
yet.
across the
Mm-hmm.
DCB.
No wire.
You know, a short coronary DCB will work as well. If you can get a
Got
Navicross
wire.
across, but if you can't, then just keep the Navicross here and double wire that with a 14, pull out the 35 and do the thing. Yeah. Then just wire with a 14. Oh, okay, there you go.
Yeah, we're at.
Yep.
Give us a 014 stiff wire, like a command 014.
Almost there, PK, almost there.
Let's see here.
Yeah, no, we're almost there. And then Ajit and I want to talk a little bit about management of the groin. So we've got antegrade access. The question is Kelt versus perclose. I'm curious what you guys think. And then we'll demonstrate the Kelt to the perclose. I don't know what you guys do. Very curious to see what your thoughts are. How do you handle
command 0-4?
How do you handle it, Stephen? 0-4.
0-8 or 0-4?
Because we're doing a corner DCB, right? DCB. Oh, we can do 0-8. We can do 0-8. 0-8 command is fine. I'm sorry, guys.
Command high torque 0-8.
I mean, just use the closure device that you're familiar with, PK. I mean, that's.
But what do you guys recommend?
I only use Angioseal and perclose in my Angioseal is squash, but I'm not familiar with the Kelt.
Al, what do you guys do? Al, what do you guys do? And any, I don't know what.
My partners love the Kelt. I still pro-glide everyone.
Bhaskar, I don't know who else is there. I'm sorry, guys. I wasn't fully aware of it.
I like the perclose too, but I would like you to do the Kelt so I can learn.
Oh, sorry. There's not a Kelt course.
He already has a Kelt, right?
It's not. He has 7 Kelts, but there's not a Kelt course though.
I don't know. What do you guys use?
I would still think some low pressure. The thing about the drug-coated balloon, the ranges are that.
Oh, you don't have short? 60 is fine.
Sometimes when you're not coated.
It's 0-8, right?
So well around the tight area there, so.
Wait.
So what size for the drug-coated balloon?
5060.
Short 5?
Yeah, it was good.
It's 0-8.
Is it 0-8? Okay, 0-8. 5060. $50.60. So Al's right. I mean, I'm tempted to put a coronary stent here.
Do you worry about it getting crushed though in this location?
That's what he said. He said there's not a crush
I
zone.
tell you, it sounds that way, but I put coronaries in the foot. I even put the bioabsorbables in the foot. And I even put coronaries in the ankle and just casted them for a month and thinking, once the wound heals, then they close. But interestingly enough, they don't close. So it's odd.
Huh.
But that area, I'm not sure there's a lot of motion in that space there, to be honest with you.
I just worry about someone trying to feel a pulse and like crushing it, like one of my fellows.
Yeah, you want to laugh about that? I went crazy because they were doing ABIs on our patients, and I said,
Oh, yeah.
tough on the tibials. But apparently, some of my partners have been doing it for years. They've never crushed a tibial stent, which I find odd.
Push
If
the
you're
wire,
compressing
please.
enough
I'll look
that
over.
you're including the
It's not
artery,
coming.
why is it working? But
Okay.
they say no.
Nah, the DCB is not crossing.
I think we might just need a regular.
Yeah, just dilate it again with a 5 and see what happens.
Oh my God.
It's not coated. That's why it's not lubricious. Cross. Yeah.
All right, give us a 50 regular coronary balloon again.
0-8 or?
No, we don't. Give us an 0-850 balloon now.
Okay, it looked like it moved forward a bit.
You want me to try again?
Okay.
It looked like it moved forward a bit.
Oh, I'll try bending the leg, see if that helps.
In the water, perhaps you want to push it up a little more.
No? Okay, just pre-dilate and then bring that in. Almost there.
It's not going.
The worst case is a 014 DCB or coronary DCB. The worst case.
Well, coronary DCB, Sharma will have my head.
Got a Lima section?
Boy, the price.
Not going.
Yeah,
Oh, they're very expensive?
Yeah, exactly.
Oh, yeah. Okay.
Agent. That's a nice.
Agent is expensive?
0-8 for balloon, short 0-8 balloon. 80 is all you got? 40 is good.
Hey, Hippocrates, the agent.
At this point, go for gold, right?
1,500?
I can't hear you, Jose. Sorry.
I know that they're very expensive. I forgot how much.
The coronary DCB is $5,000.
They're 0-4.
5,000.
Yeah, the coronary DCB. That's why.
At this point, PK, go for gold because it's building.
I tell you guys.
All right.
You guys. All right.
Rough crowd, right?
I'm telling you. At least we kept at it. So let's see. I mean, if we got to get this open, yes, sir.
Okay, you're still ahead because
260?
you're at 3 hours. Because remember, I told you my first
give it
case
that?
you at 4.5. You're
You get
still ahead.
2000? Yeah.
Don't worry. Don't move so fast, okay? Take your time.
It's not going. Nope. Nope, not going.
Hmm.
We're going to have to go with an 0-4 here, guys. All right, walk it out. Give me the Trailblazer again.
You got the Sterling balloon PK, like the monorail?
Yeah, I don't think it matters here, Bosky. It's just not going.
We have that O&A
Give me a
camper.
Trailblazer. It's right here. So give us another 0-4 while we have it. So let's give us what we have. And then Dame, I need a 5-0 0-4 balloon.
Could be the wired.
We could try a guide. We could try a Guidezilla. Take a Guidezilla down. Dame, get us a Guidezilla.
This is
They have the coolest names.
We had like
an
a
extension
command wire super stiff.
Are you guys in the F&B business? Because it looks very much like a buffet.
Yes, sir.
This is a Mount Sinai buffet.
Oh, barely.
Okay, good. All right. Now give us the 0-4 wire. And Dame, give me a 5-0 0-4 balloon first,
We have
and
that
then we'll
super
try the
stiff
Godzilla.
That was one I
But
handed.
Is the Godzilla that long to get you? that
Super
far
stiff
down?
command.
We're antigrade, right? So it should be good.
90 gray.
Oh, okay.
120
We
centimeters.
have a Grand Slam or something?
Yeah, Grand Slam's fine.
Well, up and
That's
over.
gonna be right there.
Are they integrated? You was up and over?
You know, he's 90 gray, 90 gray.
Oh, okay.
You okay with that tip or no?
Let me see. Yep, that's fine. It's absolutely fine.
Should just hopefully J up.
You good?
I'll just take this out. Yeah, I'm good. You can keep advancing.
All right, going on a Grand Slam. Hopefully it'll work. I think if we just get that with a balloon, it might be enough.
Well, worst case scenario, don't put a DCB, just use a plain balloon and come back another day if you need to.
Well, we're definitely going to do a plain balloon first, and then we'll see. 5-0 plain balloon, 0-4. 5-0 15.
See, in the future, you
Coronary.
I'm quite sure there will be missed.
How will you?
A little bit more, bro.
Oh, location. Maybe just DCB, STCW. Let it run.
And then get the guy. The Godzilla
You don't
is
laser or anything though, right?
Godzilla's a 6 French, right?
Out of the venue.
You have a 7 French Godzilla. What's the lumen of the 7 French? Karthik, see if the 018 DCB will go through the 7 French Godzilla.
Okay.
018, most like, yeah. The sheet is 8. No, don't think you go.
No, it won't go. Yeah, it'll go. Let's try. Wow. All right, let's go up here, and then we'll go up again. We'll try. I don't know, brother. Even though 0-4 balloon.
Hey, that's 8.
Okay, down. Okay, go up here.
Nice.
Probably the struts of the stent.
Not yeah. Hold on, not yet. 10, 12.
Uh-huh.
Down.
The line never got pulled out, so we're not through the stent strut, I hope.
Go here.
Yeah.
I think the DCB will run right now.
Down. And now it's balloon here again one more time. Down.
Okay.
Okay. Let me
Wanna take
just
a picture and see?
let me see how this moves. Go up again.
Definitely better.
Yeah, I know, but it's just not smooth to go in, so I'm going to go up again here.
Prakash, you're not through a stent strut, right?
No. I never lost the wire. No, down.
Okay.
I never lost the wire, brother. Go up again. Down. Okay. Go one more time.
Mhm.
Okay, down. All right, let's see. It's at least going. So give us the Guidezilla. Let's try with the Guidezilla.
You got wire?
Yeah. Mm-hmm. Mm-hmm.
Yeah, so.
Oh, you got it. Great. So this is nothing but a guide extender. So what's going to happen is I'm going to go into the vessel. I mean, I hope Karthik's right. I hope the O1A balloon goes through this.
Hey, Prakash, what is the length of those Godzilla?
Dame, what's the length of the Guidezilla?
120, guideline or whatever.
And this is a 6 French Guidezilla, PK?
Yeah. No, 7 French.
7 French.
Show me above. It's 150. Show me higher, brother.
Yeah.
All the way up. Mm-hmm. All the way up, brother. So you got to watch the transitions like this. See right there, there's a transition. No, it's not working here.
So you don't want to advance the balloon first and then slide it over the balloon like we do with coronaries?
Yeah, that's what we're going to have to do. Okay, give me the 4.0 balloon, guys. a 4.0 balloon. Godzilla, yeah.
You need a second wire? Or?
No.
Excuse me?
Put a balloon in and then slide it over.
You just slide it over it like a dilator.
Yeah.
There you go. Yeah, I got it.
But they have their
What?
system called trap line, which is a dilated.
Razor? Oh, it should be fine. We had plenty of shaft line.
Putting a guide extender, but it's not going down. So
No, you're through.
And then sliding the guide extender over the balloon.
See like that? You see that? Come down, you see what happened? It just slid over the balloon. Show me down, guys. So it just slid over the balloon for me. So now I'm just sliding it all the way down the guide extender. So that as the guide extender will come down, see now how much support I have. See now I need to balloon this area, so I'm going to go with the balloon now. This is the balloon, yes. So I'm going to go with the balloon now. Ajit, you're going to go up with the balloon in a sec.
Mm-hmm.
So there's the balloon. We're going to go up here with the 4.0.
I do balloon distally and then push it down.
Mm-hmm.
All right.
$12.
Uh-huh. That's 12.
Okay, hold on. Get down. So you just use that as a little slide and then bring the balloon down further. Try to slide the guide over, Guidezilla over. I would like to go across the bend if I can with the Guidezilla, which will then allow my DCB to track.
So advance your balloon, inflate it and trap it. So
That's what I'm trying to do here, brother. Go up here just slightly.
Gosh, what's the biggest balloon
Down,
you can
down.
get though, guys? What's the biggest balloon you can get through a 7 French Godzilla?
Looks like a 5.0, Al. Go up here, Ajit.
you may want to get a new balloon now. So.
Down.
Because you lost.
Oh, the balloon just went.
See, now I'm across.
Nice.
So now my guides. Now if I can go with the balloon with the DCB, it'll be wonderful. Whoops, sorry, my bad. Losing wire here. All right, give us the DCB, guys.
We never
we
inflated
didn't
it.
inflate it, right?
Will the DCB
Yeah, get us.
Oh, for the drug.
I believe it should. According to Karthik, yes. So I believe everything
The
Karthik
full
tells me.
French device.
Karthik's name on the line. Jose. Karthik's name.
Yeah, get Karthik on camera for this.
Yeah, Karthik.
Yeah.
His name is on national television now.
Never used.
All right. Let me have the DCB. Yep.
I think you can go.
Bhaskar is saying no. Karthik says yes. Let's see who's right. I have a good feeling.
I'm gonna say no, but.
And this is a 5 DCB PK?
It's a 5-0.
5-0.
You got wire?
Uh-huh.
Can you just rail me, please? So you need to show me up slightly, Ajit, because what you'll see is there's an area where it's got to go through the guidezilla. Show me above the... You're railing me, brother?
Yeah.
Okay, so see that right there. You see that entry point? That's the point. You got to stay there.
I think you went through it, right?
No, I'm not there yet.
No.
No, I'm not there yet. Am I? Show me down.
But you're protected the whole way. What's the holdup, PK? I don't get it.
No, will it fit is the question. Rail, guys?
Okay, rail.
There it comes. You see the balloon? Hopefully it enters here. And Bhaskar's right. It's not entering.
It's only a tip. Yeah.
Yep, it's not entering. Oh, it went.
Oh, it went. Oh, wow. Karthik.
I thought it was not gonna go either.
Yeah.
Is it?
So this is a neat little trick. So now you get it across the bend.
Very cool.
He uses a lot of equipment.
See, now I'm across the bend, so I'm going to pull the guidezilla back now.
So for sure, you need to use a 7 French guideline.
See, now Ajit can go up. So Ajit can go up with the DCB. And hopefully we can, this will do it. Let's see. See, there's the DCB now.
Nice.
All right. So now we'll go up to whatever nominal 8 or 9.
Yep, that's 8.
All right, we're going to leave it up now for 3 minutes. Woo! Stephen Coombe. Oh my God. So this is kind of cool. So you guys got to see a guidezilla. You guys got to see a twin pass. Kind of cool stuff here. So definitely.
It's a buffet.
It's a buffet. He's okay?
Still on the balloon.
Drug-eluting stent will not go through the guidezilla, right?
What do you mean? You mean Silver? No way. Or Illuvia? No.
Illuvia?
No. Nope. I banged myself in the leg, as you see. There you go. So somebody's got a timer on?
Yeah, it's on. You're going to do what, 3 minutes?
3 minutes.
Take a little break.
Yeah, Jit and I have been standing. It's crazy.
Where's the sitting stool?
Well, I'm glad that we were able to get through, and we're glad we're able to go, connect the circuit and create the circuit. I mean, Ajit spoke about this, that the AT is going to be a problem. Thank God you were right and you were wrong. We got through it. So now I am worried now about the fasciotomy and those other things.
So yeah, it's going to be like a small hematoma evacuation. It's not like he has a reperfusion or anything. So I'll just drain whatever I can just to soften it up. Honestly, it already feels a little softer, so I think it kind of diffused a little bit.
Ajit, sometimes what I do is I do the fasciotomy. I take a drain from the OR and I put it in, close up over the drain and let it, because you're going to be anticoagulating this patient a little bit. So sometimes you can put a drain, just stick a drain in and then close up over the drain. And,
yeah.
Can you just check if the pressure is too high in the compartment?
If you're thinking about it, you should do it. Yeah. And PK, I think you should put a short coronary stent on top, just to make sure that the inflows, because the cheap within and out, since it's really cheap here in the US.
See, already Alfio is calling my administrator, and you know, I mean, I'm gonna blame Majid. He's gonna blame me. We're both gonna be in trouble. Dr.
Well,
Barrett.
we'll split the cost in two.
Far away.
I think let's take a picture from top
Yeah,
down.
we'll take
and
a lot.
see.
We'll take a picture. We'll all decide together. So we got 30 more seconds.
What's the reasoning, Stephen? Though, is it even if it's a healthy segment, you'd still do that, or only just because you think it's diseased?
It started out healthy, but I think it's been cawed out by the sheath a little bit, and I'm not fully sure that the proximal edge of the covered stent is fully expanded. And if you want to balloon it, you injure the proximal AT. You might as well just slap on a drug-eluting stent and
Would you use a bioabsorbable or a drug-eluting here?
just go cheap. Just use a coronary.
Got it. All right. So 3 minutes are up here. So what I'm going to do is walk both my guide liner and I'm going to have Ajit walk out the balloon.
Okay.
So I'm just going to pull the guide liner back as Ajit walks out the balloon.
Stiff. You're on the floor, right?
Yeah. There you go.
Stiff.
You got it.
There we go.
No, that wire is going to shear. We got to be careful.
Maybe at nominal. PK, is there something wrong with the 14 wire?
Yeah, it's going to shear. Ajit and I just saw it. Yeah, we just saw it.
Well, it's still hanging, so.
Yeah, we're going to be careful. All right, DSA guys, ready? I got it here. It's from here.
You may want to advance a catheter down before pulling all that through the stents.
It's a good point.
Let's see. Do you want an 014?
Oh, beautiful.
That's an Autobahn, my friend.
That is beautiful.
Nice.
That's good, right?
Very good result.
So any other views, Stephen, we should look at?
No.
Well, I think look at the top, and after that, the only view you want to see is the bar.
Okay, you got it. All right, let's do a DSA here.
You want to do a lateral so that you can see the offtake of the AT, and then so if you need to stand, you can stand straight away.
So when would you go to?
That looks pretty good, bro.
Yeah, it looks great.
Stephen, that looks good, man. Why are you going to stent that?
I would highly recommend a stent.
All right, so give us a coronary stent, guys. Give us a
You know
4.
what? It's interesting. Look at that run. I think Steve's right because look, you see that laminar flow on the stent there?
Yep.
I think you have a ledge. It's creating turbulence. You may not just see it. If you ran an IVUS, you probably see it pinched in a bit.
All right, so give us a 3/4/38 stent. 3/5.
I think you can use 3/5 and take it up to 16, and that looks like a 4 vessel to me. What kind of field of view do you have?
Actually,
Just
38.
7 field of view. So looks like a 3/5 going to a 4, and I don't think you have steel. Looks pretty decent. The flow down the native arteries is quite fast.
So you take it just to the ostium or across the TB trunk?
So I think just keep it on a straight portion, maybe about 2 centimeters, above the covered stent.
Oh, you want to be no, I'm going to go into the covered stent, Stephen.
Yeah. But just 2 centimeters exposed. I mean, just treat the vessel maybe just above that collateral with that.
Yeah, just hit the ostium. Yep, agreed. And then we'll be done.
And you're quite sure maybe a 28 would be enough to do that.
I asked for a 38.
That'll be fine. 38 didn't cover the whole.
I know that we did.
So you're going from the ostium all the way covering those collaterals?
Just beyond the ostium.
It's not really.
And okay, don't forget the balloon in posterior.
Anything in the pop? You see the pop at the edge of my sheet? Edge of our sheet?
This is something I always encourage.
Leave it, right?
Yeah.
Okay, we're not going to chase everything now.
Vessel before you start the DVA, because after the DVA, you're so tired, you just want to get out of there. Always treat
3/5/38
arteries before you start the DVA, because you see this, you want to get out of there. So
doesn't matter.
Forget the native
Anything.
circulation, you want to balloon that.
Science is fine. All right, so we got to.
It'll just suction the blood right out of it, right?
I'm sorry?
It's like a siphon, it'll just suction the blood right out of
Got
it.
a little bit of hematoma going on here.
Yeah.
So we got a 3/5/38 cipher going in. Not cipher, Zions, I'm sorry.
Sorry.
You taking us back to the 60s or?
Huh? Yep, you could start. Yeah, go now.
You must be very tired.
Cyphers came, what was it, 2002?
Withdrawn 2014 or 2015.
No, it was a fellow with big pickup.
There you go. Ready?
No, it came after
Yep.
2002.
All right. So we are going to go. Okay. So, oops, sorry guys, my bad. Okay, I got both. Thank you, Ajit.
Yep.
I'm gonna just have David just puff out here. Dave, oh, it's gonna be a little short. A little puff, David. This is a 38, and we're still gonna be a little short. We'll leave a little gap. Little die.
That's okay.
Well, do you want to leave the gap if that you think the edge of that stent's causing?
No, we can go in. Yep, no gap. Okay, let's take a picture, David.
Okay.
I think we're right at the ostium. I think we're good, right? Yep, go up.
What's nominal in this thing?
I just go to 20, 18.
All right, 18 it is.
The buzz 16.
I think 12 is nominal.
It's a suggestion.
12 is nominal.
12 is nominal.
18.
And we got bigger.
Okay.
Down. Go up again, brother.
So if that was a
Okay.
3.5, it's probably not
Yep.
4.
Yeah, it's 3.5.
Okay, you want to push the balloon down a little bit to even out?
Now go here. Go to 20, Ajit.
Go what?
20.
Okay.
So that's going to be a 4 mil, but
No, it's at 3.5. 20.
yeah, but the coronary stents
That's
now.
20.
You're probably 4.0.
But
No,
it
it's
should be fine. I don't think you get steel. Significant
No, it's
steel.
a, it's a
I think it looks
3.5.
okay.
It's I put a 3.5 coronary stent, not a 4.0. Go up here to 20. I just put a 3.5, guys. I didn't put a 4.0.
I know, but a 3.5 at 20 atmospheres is probably 4.0, right?
No, down. No way. It's like 3.67 or something. Dame, what is the size of the stent at 20 atmospheres? Ready? DSA?
DSA? DSA?
What is it at
Okay,
20
money
atmospheres?
shot, my friend.
Yeah, it's 3.8 at 20 atmospheres.
3.8?
Yeah,
Okay, in between. Nice.
Looks better.
that's good. All right, foot shot, lateral foot shot.
Watch your knees.
Yep, I'm watching my knees. Dame, we're out of die, buddy.
You want to take the wire out for this one?
We're out of die. We're out of saline.
I'm going to hang on to the pedal a bit and see whether the native circulation comes down the back.
I have some
Yep.
contrast in a syringe if you just want to use that.
That's a great idea.
And the PT.
Yep.
Great.
Yep. Nice.
You're good with that?
Yep, looks good. PK, don't forget the balloon, the posterior circulation a little bit.
You want to balloon the posterior circulation?
Yeah, the stenotic area, remember on the angio, there was a stenotic area, very tight.
That's a good point.
Just below,
The vein or where?
Oh no, the artery.
Oh.
Give it. Yeah, give us another. Give us a run through, guys.
Looks beautiful.
Yeah, beautiful. All right.
Congratulations, PK.
Oh yeah, well at least we did an anterior DVD, PDAV, and then next one we'll do
Yeah,
a.
we can- I mean,
give me a
PK,
2.530
your
210.
experience between the posterior and the anterior, right? What do you think?
Oh, Ajit and I like posterior all the time.
Yeah.
Every day.
Preferential PT.
Every day. Yep. Where is it?
You guys did a great job, man. It's really not
Yeah,
easy.
no, it's incredible learning, really good learning.
Just before you leave, just do a flexion of the leg, just a CNE, just to see those stents.
Absolutely. We'll do it in a sec. Let me just go ahead. I just checking out the. I'm going to go into PT now.
It's actually fairly soft.
It's fairly soft, so we may not need a fasciotomy. I think we'll see.
Let's see.
All right, show me the popliteal, guys, so I can get into the PT. Give me a 2.530 210. That's great. 2.530 or 3.5? No, 2.530. It's a 2.5 vessel distally. Oh, that's fine. Whatever you got is fine. Yeah, it's fine. My tip sucks here because it's not a tip, but anyway, I'll use the balloon to straighten it.
Beyond this.
Yeah. Where was the stenosis?
Right above the ankle.
Where the two wires cross.
Oh, okay.
Roughly around.
Oh, yeah, you passed it already, I think.
Yeah, I just got to get down there. It's very calcified, as Ajit was saying. So, just straighten it. You want to straighten the loop and just cross it, Ajit?
Yeah.
There you go. Now just see if you can cross it. No,
Not easily.
it's not going easy. Maybe you might need another wire.
Yeah, this wire is kind of jacked
All right,
up.
give us another one. Yeah, that's fine. Command's fine.
You need to get lower than that, though?
I don't know. I don't think so. I think we're okay.
You crushed the lesion already, I think.
Yeah.
Yeah, I think you're right. We'll go up. So Stephen, why are you saying to do this? Because you're worried about the donor artery?
Because as humans, we always want to see a nice result. And once we see the venous DVA result, we leave all the untreated arteries alone.
And so why is it important? Why is it important to treat this though? So why is it important to treat this?
Because if you don't, then if you have a subclinical steal, for whatever reason, the pressure system in the native artery is so high that the blood is preferentially going to go down the DVA circuit, and you're going to get a steal.
Yeah, I think you're past it, so
Same time.
that should be good.
You want me to balloon all the way into the foot? Okay.
I think you're past it.
Balloon from here then?
Yep.
Okay. Go up nice and slow. So
What balloon is this?
The 3.5.
3035.
Is this 2025?
3035. He's a big guy.
Nanocross?
It's a nanocross taper. So it's obviously very
4.
dilute dye.
That's 4 atmospheres though. So
We go to 5.
mm-hmm.
What? Okay, señor, lo siento.
What's going on at the stent in the front? Did it slip or what is that?
Right at the ankle.
No, there's plenty of overlap.
It looks a bit weird over there.
No, that's good. Perfect. No, there's overlap. That's overlapped. 10.
Right, it's just the stent not fully expanded. Is that right? Or
Yeah, just above the.
Right here.
Okay, down.
it's a bit weird.
Yeah, it's not-
Show me above. Go up here.
That's 5.
6.
Mm-hmm.
I just go to 8 and then 10.
Okay.
Yep. Leave it up. Is that come a little bit off the bone? Make sure it's expanding. Okay, that's good.
Yeah, I think it's good.
Down. Down. All right, David, ready to inject? Ready, David? You ready? I'm down. Obviously, a lot of steel down. Show the foot. I'm going to do a delayed cine now. Okay, get this off the foot. Okay. Sorry, sir, like that. Inject, David.
stealing, right?
I'll see if they want it. Another one.
Can I put a catheter in the PT and inject directly?
Was it that slow before we ballooned?
Show me above, David. Rail the wire, David, for me.
Dissection and no stealing.
Okay, wire out, David.
Wire out.
Give me. I'm going to inject through the balloon.
Just make sure you don't have a dissection, you make it worse.
It should be okay.
You want some phaser?
Because
Yeah.
he seems to be stealing more now than before.
Yeah, I tried.
Ajit, maybe you should be doing the fasciotomy just to make sure that things are nice and soft. What do you think?
Yeah, I mean, the DVA flows really well.
Can you show me?
I just think we spasmed it, or, you know, maybe a dissection or
A little
something.
lower.
I was worried about pain. You get either from the swelling or
Yeah.
a bunch of stuff.
Okay, everything looks good.
Yep.
Everybody, I'm good. Everybody good with that?
Looks good.
I'm going to show
You
a
wanna
little
shoot
bit above. Yeah, I think it's okay. We should be good here. Ah, I broke my syringe. That's open. Okay, good guys. So we'll do the per close. Okay. Oh my God. All right. So what do you? So, well, let's take a look.
PK,
Yes, sir.
you can do a dry CD of the ankle when you move the ankle. Just take a look at those.
Yeah. Let's put me on coronary, guys.
And a lateral projection. Just have a bit of just for the learning exercise and see what happens to those stents. I know you're tired, but
No, we're not tired.
come on,
No way.
titanium.
Okay, ready? No inject. So no, not kinking at all.
Yep.
Okay, ready? Inject. Inject. Okay, guys.
Yep.
All right. So let's do that. We'll do the per close here. So.
We open up a per close.
You want to do a Celt or per close?
How did it look?
Let's take a look. We have both. That's the shot.
Do an access shot. I mean, we could probably use either.
Okay.
Want to Celt it?
Let's Celt it. Well, I think Celt is better. All right, we're gonna Celt this one.
7.
7
And
French
we need
Celt.
a short 7 French sheath.
Short 7 French sheet. 7 French
Super
Celt.
core?
Yep, super core is right here. Great case.
Yeah.
Oh, for some reason I thought you came out.
All right, 7 Frenches down. So I'm gonna walk them out here. Ready?
Yeah.
All
You got
right,
wire?
I got it. I got wire.
Okay.
We'll do the report together, obviously.
Thanks, boss.
That's the Rabe sheet feature, 755 Rabe.
Yeah, we used the Cook because we needed a 55 centimeter sheet to get into that proximal AT. So, you know, difficult case, but anyway, it was done. All right. So Celt's in. Where's the 7 French Celt?
Right here? Right there.
All right, Ajit, you want to walk them through?
Yeah. So kind of we're talking about algorithms. Mine is per close for healthy vessel, small unhealthy vessel, either manual pressure or a Celt, because the Celt's pretty low profile, so it doesn't catch things. The only downside I think that people complain about is you leave a disc there. But anyway, so this is kind of what it looks like. It's very similar to a Minx, except you're kind of substituting the balloon for a metal disc. Now, antegrade is a little challenging because you're putting in this kind of like metal rod into the sheath, and so sometimes the bend doesn't really take it well. So the main failures I've had are antegrade, which might be one of these. We might need, oh, there we go. I still don't like how it feels.
You don't like how it feels? You just
No.
want to do per close?
Yeah, we should just do per
Per
close.
close, guys. Up. There you go. Maybe not. Maybe not.
All right, we'll try.
Let's see.
So, all right, we'll try it. But so now it has, oh good, you zoomed up. So it has 2 discs to it. So the first one is kind of like the disc on the inside. So that's going to catch the arterial wall as you pull it back.
Oh.
So you can see that disc. And then it has also this hemostatic valve, if you can see it, so it bleeds when you're inside the vessel and then stops once you're on the wall. Anyway, we stuck right above the other celt, I believe, right?
Yep.
So it should start catching something soon.
Right there. Yep.
Good.
So this is like a glorified angioseal.
Oh, let me give a.
Yeah, similar concept. So now,
1 second, just
the
send
other thing.
Cindy so they can see it.
Okay.
Oh,
Injector.
this thing is down? Oh. Okay. Cindy? Yeah.
Is it still up on the up
Yeah,
and over?
may not
Maybe?
be in the aorta. Let me see.
The other nice thing about this is you can see it on ultrasound, so you can actually see it catch the wall, which is why I like it so much. So you know you're not getting the back wall or anything.
Flora, brother?
Uh-huh.
Oh, yeah. So it's not even in the aorta. Okay. If we come down now, we'll do a DSA. DSA? Okay. Off Flora for a sec. Good.
Ready?
Okay, Cindy? So there. So there it is.
Yep. So not bleeding outside. And then to deploy it, you just twist the disc the opposite way as the first one, while keeping up tension until a hard stop, which I just felt there. Then you just has a release mechanism, this lever, you just relax and then pull it out, and might not have worked.
But is there a hematoma
No.
there or not?
Cindy?
Or in the
I'm not sure.
access site?
Say it again?
Is there a hematoma there in the access site or not?
No, we're just pulling it back. Cindy? We'll see. We'll take a look.
I might need a little pressure.
Like a clamshell device, Ajit?
Might be a little extra, let's see.
Like a VSD closure device.
Yeah, it looks like a PF closure device, like a cardiac.
It worked. So you see, we got a complete seal. So we're just gonna hold a little bit of pressure, and then we're done. And I mean, now anticoagulation-wise, Stephen, what do you recommend for Ajit and me, and what does the company recommend?
Well, I think the problem is you do have a hematoma
pressure
in
up
the
here.
calf. Ideally, you like to anticoagulate this patient with a coag, but
Good call on that.
maybe I'm just wondering whether it's because that calf looks quite tense on the anterior compartment, but you guys are there and
Well, we're gonna make a cut right now. But I think that it's obviously needed. What happened?
yeah.
The nurse just give some medications.
Give some medications, guys.
Yeah, I think it's worth, like someone mentioned, I think if you're always concerned about it, just at least do it to make sure.
So we'll just
Give
do a
that a
little
second to
quick
work.
cut here, huh?
I'll give the lidocaine a little bit
Good
to
good idea for this patient is to not wear any covered shoes.
Right.
Yeah.
Right. So like forever. Something like that.
We don't have to do this online.
All right, we're gonna make a little cut.
You can pass your scissors to cut the fascia.
For the anticoagulation, are you doing full dose NOAC or are you doing PAD dosing?
No, full dose NOAC. Normally I would do full dose NOAC.
He was on Xarelto at home.
Okay.
So we just made a little incision here.
Yep.
Cleaning it out.
So it just opened up the fascia.
It's not much bleeding.
Not squirting out or anything.
Listen.
Sorry, buddy. Deep breaths.
You put the scissors down or just
Yeah, I cut through the fascia already. My
Yeah.
finger is on the inside. And to be honest, I'm not getting a ton out.
Yeah, usually it infiltrates to the muscle, just open the fascia, and I wouldn't mess with it, because with the anticoagulation, it'll become a bloody mess. If you
Yeah.
just reach the fascia, it should be enough, the hematoma will resolve, either slowly or not, but.
Right.
Actually, it looks all right. I think looks right good.
This guy's a pretty muscular guy too, so it kind of has anatomy, but it's pretty soft.
So we'll keep an eye on it. Well, thank you guys. So we're going to sign off here for now, and then we'll get the other patient ready, and we'll see you guys back in a few.
Good job.
All right. Thanks, you guys. Thank you.